A request to everybody, please change your name. Doctor has been written. I think you have to change its name, rename.
कंचन मेरा ठीक आ रहा है?
आपका ठीक आ रहा है. बाकी कई लोग हैं ज्वाइन. They are by the name of the doctor. We cannot recognize them. Kindly switch on your video. Dr. Usha Goenka, madam, please rename yourself.
My video is on.
Ma'am, we are live now, ma'am.
Live. तो वो वाला गैलरी व्यू कर दीजिए. गैलरी व्यू कर दीजिए. ये अभी शेयरिंग बंद कर दीजिए. यस. तो गुड इवनिंग. शुड आई स्टार्ट?
I think so.
Yes, ma'am. Yes, ma'am.
सब लोग बाकी म्यूट कर लें प्लीज. Dr. Parag sir, good evening. Good evening, respected seniors, teachers, Foxy stars and colleagues. Today is a very special day for me when so many star galaxy of Foxy, Pune and Kanpur society have decided to do the joint webinar and the knowledge sharing program. Just a few days back, Doctors' Day have passed. Few of us still are celebrating Doctors' Week. This is important because every minute of every day, we doctors somewhere bring a smile and share a problem, ease a pain, and make a special difference in people's life. Just for this purpose, we share of our knowledge and learn from each other's experience. Today, on this great occasion, to bless us, along with that, Almighty God are our chief guests, teacher of teachers, national figure with great vision and mission, our Professor Dr. Meera Agnihotri Madam and Dr. Sanjay Gupta Sir. Our guests of honors are very good human being, ICOG Vice Chairperson Dr. Parag Binwale, very humble and knowledgeable person, and our own Professor Dr. Kiran Pandey Madam, ICOG Governing Council member and the chairperson of the Medical Education Committee, very humble and always happy person. She was organizing secretary along with me for WWNetCon National Conference. I thank President of two societies, Dr. Meenu Agrawal and Dr. Usha Goenka, for their great help and appreciation. Dr. Vaishali Shavan, Secretary of Pune branch, very humble in spite of being very busy in her mother's illness, always responding me well and help in organizing this wonderful webinar. Other two conveners, Dr. Charulata, the Clinical Secretary, and Dr. Chaitanya. I again appreciate them. The Charu, you were there with me in the same room in Delhi in Femtech. I still remember how politely and friendly you gave me tips for successful efforts in elections. Such a humble, charming, and helping person are you. You were busy in your father's bypass surgery. Even then, you said, "Don't worry, Dr. Kanchan, I am there." That is your great gesture. Chaitanya, best wishes to you. You are a young, active, and laborious chap. Thanks and regards to all the chairpersons, Dr. Manish, Dr. Kundan Ingle, Dr. Ashish Kale, Dr. Nilesh, and our own Dr. Kiran Sinha and Dr. Kalpana Dikshit. Every appreciation is for their greatness and is them in front of their greatness and the knowledge. My special thanks to Dr. Sunita Tendulkarkar Madam, who is a moving vocabulary and the source of knowledge. Very beautiful. And now next year, the coming president of Foxy. Madam, when you came to Kanpur, we all appreciated your lovely presence and talk. Although I think she could not join just now, she will be joining after a few minutes. Dr. Girja Wagh, Madam, I think even she has not joined. She's our Vice President-elect, very humble, knowledgeable and helpful. I know everyone amongst panelists and the Pune Society, when heard that Dr. Girja Wagh Madam is moderating the session on high-risk pregnancy, they said, it will be perfect. Thanks, ma'am, for accepting our invitation. Our expert panelists are Dr. Ketki, Professor and Head of SKN Medical College, Pune, Dr. Manglavani, past Clinical Secretary, Dr. Uma, Professor and HOD, GMC, Baramati, Dr. Archana, Treasurer of POGS, Dr. Shelly, and Dr. Sangeeta Arya, Professor, GSVM Medical College, and Dr. Richa Bhalla, Executive Member of KOGS. Vote of thanks will be given by Professor Dr. Seema Dwivedi, Professor in GSVM Medical College. Now to start the session, I just to take the blessings of our chief guest and the guest of honors. I just request Sahiti to share the CVs of our chief guest. Sahiti, please share the CV. First, before starting our session, we want to take the blessings of that Almighty God, starting with the Saraswati Vandana. Thank you. Thank God to give us this moment so that we are collected here to share our knowledge and get the blessings of our seniors. First, our chief guest is Dr. Meera Agnihotri, my own mentor, teacher, and teacher of teachers. The next slide to share her CV and उनके बारे में कुछ भी कहना सूरज को दिया दिखाने के बराबर है. अभी मैडम ने just we along with madam organized, she was organizing chairperson of the WW NetCon, the national conference, in which the person, all the doctors from all the four corners of the India have contributed their talks, and this was super successful. The special program of the Namami Gange was very successful. Madam, just to say, she is the ex-professor and head of department of GSVM Medical College. She is a chairperson of Ethics and Research, State Medical Council, and she is the president of WW Foundation and doing much of the work for women, health and awareness. She is advisor of the Women Health Cell Ministry of the Health Government of India, and she has organized the Shapath 1000 for National Health Program launched in 24 January 21. She got ICOG Ratna Samman Award. Madam got so many national and international contributions. Thank you, madam, and thanks for always being near us and blessing us always. we want few words of blessings from your mouth.
I believe Sanjay should talk first.
No, madam.
Sanjay is our past president.
No, but it's my honor to listen to you first, madam. Please go ahead.
It's indeed an honor this afternoon to be a part of this great August gathering on a mixed web where Kanpur Obstetrics and Gynecology joins hands with Pune Society. It's always a great honor for me to share the dais with one of my very near and dear, Sanjay Gupte. I enjoy his company as an academician. I enjoyed his lectures and everything when he was president. And now he is, I must say, that's ruling out each and everything A to Z about gestosis. So Sanjay, it is always a pleasure to be with you, to learn something and to add something to my existing knowledge. The guest of honor, Dr. Parag Binwala, Dr. Kiran Pandey, and office bearers, Dr. Meenu Agarwal, Dr. Usha Goenka, Dr. Kanchan Sharma, and Dr. Vaishali Chavan. Dr. Parag Binwala and Dr. Kiran Pandey are two stalwarts of the present FOXY. Kiran has recently taken over as chairperson. So I am waiting for a number of innumerable series of meetings from her. She has been head of the Department of Obstetrics and Gynecology at GSVM Medical College in my tenure, and I know her working, and she is also very much aware with my working. Parag, everybody knows about Parag Binwale, and so smiling, so loving, listening to anything which we talk and answering. You see, whenever there is any question, the question is with him, the answer is with him, and we are very much dependent on him, on his academic agenda as well as his advices. All through conferences which I have gone through, he has been very, very helpful, and I have not forgotten as yet that Ratan Award, which was in your presence, and I believe it is one of the highest honor which ICOG has given till now, and I enjoy that privilege of ICOG Ratan Award and the lovely face of Parag and Mandakini and all foreign dignitaries with me. That is a very precious photograph for me. The conveners, Dr. Kanchan Sharma, Vaishali Chavan, Dr. Charulata, and Chaitanya. Thank you very much for being with us. I'm very happy that Kanchan, you have kept lovely sessions on, you see, postpartum cardiomyopathy, which I think we all must learn. We are also not very conversant with each minutiae about this cardiomyopathies, and nobody to talk about other than Dr. Sunita Tendulkar, who has given a beautiful lecture in our society on endometriosis and other things. Then our Usha Goenka, chairperson, she is president of our society. Very lovely, smiling face, answer of everything. She has not learned to say no to anything. And that is one very beautiful kala, which I believe very many must have learned it. And Dr. Vaishali and Charulata Bajpayee. Session 2, NCDs, again by Kanchan Sharma. And she'll be, I wish that she comes out as a chairperson of this NCD committee. The topic chosen by her for NCD, Meenu is smiling. So I believe she is expecting help from every corner of this. Now, our two important persons, Secretary of the WWCon, Kalpana Dikshit, and a very strong pillar of our conference, Sanjay, Kiran Sinha. She was coordinator of this conference, and just like a smiling face, she was holding the reins of the, you see, tent very tightly, so that we can work under this tent. So she was coordinator of the conference. Now, why I am naming it Sanjay, I really want to tell you that we missed you every minute in this conference, but you were there for gestosis out of the country, so it was not in your hand. The third session, follicular monitoring, talked about by Meenu and Manish Manchave, every learned person Ashish Kale, and it is important to learn from them. I wish I could have continued. Dr. Kundan is also there, a learned personality. Kundan, hello. And the panel discussion is also very important in this. You have done a wonderful group of experts. I will not call it panelists. They are really experts. And Ashwini Kale will be there. Girja, I'm not seeing, but Girja, I'm not able to see. Girja has worked with me and presented many panel discussions in many national conferences. So I know that Girja must have prepared it very well, and I expect that we will come out with flying colors and very good back home messages when we finish this thing. Mangla Vani, Uma, Archana, Sangeeta, Kavita, Richa, Shelly, all professor rank persons and highly trained and knowledgeable persons. And again, Seema Dwivedi from our medical college, very learned, Shiv Bhag, and her vote of thanks will add colors to it. So I congratulate all the panelists and all the speakers sitting over there, and dignitaries especially, with whom I am sharing the dais as chief guest and guest of honor and office bearers. Kindly accept my good wishes for this conference, for this meeting. Please continue them all through and come out with flying colors, with very good back home messages. I will be joining there for a pretty long time. And if I am absent for some time, Sanjay, kindly excuse me. I will appear and reappear whenever you are there. It is a pleasure for me to be there in this. Parag is not seen. So thank you, Parag, for being here. Once again, I extend my good wishes for this conference. Thank you very much.
Thank you, madam, for your kind words and the wonderful blessings. We are always, you are our
I'm not
mentors.
able to see Sunita. There are very many persons. I'm not able to recognize whether they have joined or not. Sunita is not
They will
there.
join, she will be
Later on,
joining
okay.
in later on. Yes, yes, madam. Thank you for your wonderful blessings. Our next chief guest is Dr. Sanjay Gupte, sir. Dr. Sanjay Gupte, sir, I have met a lot many times. About him, I just can say that excellence is never an accident. It's the result of high intention, sincere effort, intelligent direction, skillful execution, and vision that you have, sir. And thank you, sir, for being here to bless us. You are, sir,
Kanchanji,
the ex-chairperson of Ethics
Kanchanji,
Committee. Sir, thoda sa bolne dijiye.
No, you already honored me by, having me as a chief guest with Meeraji. That's more than enough,
Thank
she
you.
is
Thank
such a wonderful person and such a wonderful achiever. And she has done so many astounding things socially, and, still I want all the youngsters here to learn how you can be such a great person and be, so humble. See, she recognized, achievements of everybody, and really she is absolutely somebody to be you looked up to by everyone, and still she's always so humble and so nice. It really gives me a really very, very, very great vibes, always. So and I still remember, there is similarity between Pune and Kanpur in many ways. Both are cultural capitals of their state, both are food capitals of their state. And remember the wonderful conference, national conference that she had, organized. And there were so many things, and not only scientific things, but beautiful arrangements. And believe me, I'll just tell you one memory of that. At 2 o'clock at night, Dr. Nargolkar was, with us at that time. And 2 o'clock at night, when temperature was 2 degrees centigrade, he had taken us to have one wonderful, kheer, a place in Kanpur, where and I can't just miss out on those beautiful moments, Miraji, of those conferences. And that's why I really missed being with you for your conference. So any time you call me, and I'll be definitely there. And it's good to have Dr. Parag and of course Kiranji as a guest of honors with us. And of course, Dr. Meenu is now our, very active and dynamic president. She's already started the year with great, programs, and even social programs which are really innovative. She, Vaishali, and Charu with us, and of course Ushaji and all of you in Kanpur, friends of mine. Wonderful being with you, and I will not waste time in just in this thing, but I would really like to listen to the proceedings, and definitely I'll be around to listen to it all. So thank you again for having me here as the chief guest, and especially that too with Miraji. Thank you so much.
Thank you, sir. We are obliged by your nice words and gracious presence over here. Next, I welcome our guest of honor, Dr. Parag Binwale. Dr. Parag Binwale के बारे में उनके CV पढ़ने से पहले मैं इतना कहूंगी, sir, you are really a wonderful person. You are a good human being and a warm-hearted, affectionate person. I always whenever I meet you, I have these feelings, and I even when talk, there is a very good, affectionate person inside you. You always guide in the right way. Dr. Parag Binwale is at present ICOG Vice Chairperson. He is a senior consultant. He is a PG teacher. He was president, yes, Pune Society. Yes, there are many contributions, many award, or there are so many things about you.
Thank you. That's very sweet of you. But then when Madam Meera ji and Dr. Sanjay Gupte are sitting here, they are such big stalwarts that you don't have to introduce youngsters like me and even Kiran ji for that matter. First of all, thank you very much for considering me worthy being the guest of honor and sharing a virtual dais with Dr. Meera Agnihotri and Dr. Sanjay Gupte, who is our mentor in Pune. Madam Meera ji, you did call me for the conference, but unfortunately I was not here and I could not make it. And for last 2 consecutive years, I've given Kanpur a miss, but I promise you that in the near future, I'll certainly be there in Kanpur with all of you, exchanging some knowledge. And of course, I can't forget the Thaggu ke Laddu, which are so famous from your city.
Parag, your attendance is short here. So kindly make it up.
Thank you. Today's program is really an interesting one because it's a different kind of Sangam, though there are 2 different cities in different parts of the countries. But as Gupta sir very rightly said, these are the cultural capitals of their states. And when these 2 cities come together, it is going to be a great exchange of knowledge. So without wasting a time, my best wishes for the program, and I'm looking forward to a great learning experience. Thank you very much.
Thank you, sir. Parag sir, thank you for your nice words. Our next guest of honor is our own Dr. Kiran Pandey, madam. This is my good luck, and that I used to meet her and take her blessings. About her, I can say that madam, your soul is beautiful and your talent is a God's gift to you. Madam Dr. Kiran Pandey, as you are beautiful, your soul is also very beautiful. You always bless us. Madam, you were the professor and ex-HOD, Department of Obstetrics and Gynae, GSPM Medical College. You are the ICOG Governing Council member, peer reviewer of the Journal of Obstetrics and Gynae, and you were the chairperson. You have many of the work experience research activity and so many awards that we always discuss here in our faculty. Thank you, madam.
Thank you very much for your
blessings. We need
for your kind. I mean, I'm really, really honored to be sharing the virtual dais with legendary figures of the India, Dr. Meera Agnihotri, ma'am, our most we always get devoted to her so much, and she's such a kind-hearted person. Dr. Sanjay Gupta, very knowledgeable person, and whenever I don't know, Kanchan, you have that experience now. Whenever it comes, you must have seen in the meetings, whenever there comes a time, some decision important has to be taken. I think every president and the whole general secretary looks towards him to give the final opinion. That I've seen many times when we have attended those meetings. So, I mean, really, it's my proud privilege to be there. Dr. Parag, for a long time, we have known each other, and a very I would say, thanks for giving compliment that we are young, and he has included me also into his category to share the dais, and all the important, eminent speakers who are going to talk on the mixed thing, the postpartum cardiomyopathy, which is a very important thing for each and every obstetrician who's working in labor to diagnose it, to save the mother's life. NCDs, which are the incidences, are increasing, so that Kanchan, who knows better than that, because you are very much concerned from the NCDs. And mixed thing you have kept, that's a very good thing. With the Pune Society has come out forward and sharing the things with Kanpur, the follicular monitoring, the panel discussion which you have kept. I've seen the whole program. It's so much, each and every part of the obstetrics and gynecology you have taken into it. So I'm really, I don't want to waste time, or I don't want to take a single minute from the speakers because everybody is eager to learn from them. So thank you very much. And I'm really obliged and happy to share with it, to get the blessings from Meera ji, to get the blessings from Dr. Sanjay Gupta, and good wishes from everybody. Congratulations, Pune Society, to be there. Meenu Agrawal, we have talked many times together. And of course, our society, Usha is there, Kiranji is there, Kalpana is there, Shelly is there, and also many of the persons that we know each and everyone through webinar has done. The COVID has only done one good thing, that everybody has come close from all over the India at one dais comes. So really good thing. Thank you, Kanchan, for giving me this opportunity.
Thank
all
you, madam.
my wishes are with you.
Thank you, madam. We are blessed with your presence. Now I am seeing the presence of welcome Dr. Sunita madam and Dr. Girja madam. Madam, we have told many good things about you. We will be repeating it. Just first of all, we will be starting the session.
It's an academic session, Kanchan. We understand the sentiments of everyone. Please don't repeat. And our all greetings to our own Dr. Sanjay Gupta, Girija, Charu, I'm seeing, and Dr. Meera Agnihotri, Madam Kiran, 3Ks of Kanpur. I'm so glad to see you all. Meeraji, thank you so much for having us here.
Thank you. We were waiting for you.
I know. So, no, Kanchan informed me that Meenu wants to take the first lecture, so I said no problem.
Because she is in Dubai, so
no issues.
Dr.
I'm
Meenu
absolutely okay. I'm in my cabin.
Session. So without any delay, we just proceed toward the first session. Dr. Meenu Agrawal, she will be speaking on the follicular monitoring. Our three learned chairpersons for her talk are Dr. Manish. Just show, first one is Dr. Manish. Dr. Manish is a very senior person. He is MBBS, MD, DNB, MNA, MS, FICOG, LLB, Diploma Pelvic Endoscopy from Germany, and Advanced Diploma Gynae Endoscopy Surgery in the France. I have met him when he came to our Kanpur for IAG. He's a very good, gentle, and learned person. He's a consultant obstetrician, gynecologist, and gynecological endoscopic surgeon with 20 years of experience. He's a consultant of Maha Chave Hospital and Sahedri Hospital, Ruby Hall Clinic, Honorary Kamla Nehru Hospital, Dr. Tarabai and Limai Hospital. He is the ex-vice president of Gynae Society Pune. He is the chairperson of Ethics and Medical Legal Committee of POGS. He is a life member of many societies and one of the founder member of the Pune Association of the Gynae Endoscopic Surgeons and ex-lecturer Department of OBGYN. Welcome, sir, here. Dr. Manish, sir, I welcome you here. Dr. Kundan Ingle, he is a vice president elect of POGS. He is a chairperson of Infertility Committee, POXI 2022-23. He is a managing council member of ISAR 22 to 24 and director of Nimriti Clinic Center of Assisted Reproduction and Endoscopy, Pune. He is a vice president elect of POGS 23 to 24 and founder treasurer of the Maharashtra chapter of ISAR. He presented research paper at ASRM 2020 on prospective RCT of estradiol validate versus estradiol hemihydrate in FET. Wow, sir. He is the owner of MOSES Cradle ART Bank, Pune. He presented first time research at 6th COGI World Congress at Vietnam on use of GCSF subcutaneously for the thin endometrium. Great achievement, sir. Welcome. I welcome Dr. Kundan Ingle here. Dr. Ashish Kale, he is a chairperson of Family Welfare Committee, FOXI. I welcome you, Dr. Ashish. You have great achievement. You are MD, DNB, MNAMS, FICOG, FICS, and FICMCH, Pune. You are a director of Asha IVF Center, director of Asha Kiran Hospital, Pune, and FOXI member. You are chairperson of Family Welfare Committee at present, clinical secretary, so many posts you have held here, and recipient of so many awards, IAG, Agal Skill Excellence Award, and ISAR Youth Icon Award, so many awards in your cap. I welcome you here. And I hand over mic to chairpersons for introduction of our speaker of the day, Dr. Meenu Agrawal, President POGS.
Thank you, Dr. Kanchan. I hope you are hearing me loud and clear.
Yes.
Thank you, first of all, Dr. Kanchan, for inviting me to chair this first session of this August gathering. With respect to our chief guest, Dr. Meera Agnihotri and Dr. Sanjay Gupte, and all the respected dignitaries present for this workshop. It's a privilege to introduce my president, that is Dr. Meenu Agrawal, under whose care I am also a vice president of Pune Obstetric and Gynec Society. And I'm very happy that whenever she leaves Pune and India, then I automatically takes charge of presidency here. So thank you, Meenu, for giving that 2 days of presidency sometimes. But Meenu, I think Meenu, it's a very wonderful person, and she has really started Pune Obstetric and Gynec Society activities with a bang of installation conference. Not only that, she's a very active Foxian. Recently, she has done a chairperson post of Imaging Science Committee. I was there 1 year parallel to her chairing another infertility committee year. So 2018 to 21, she has started ultrasound training courses, which has become a landmark training courses for Foxy. And I think it is still continued even present year. And not only that, another feeder to her cap is she has been elected as a board member for International Society of Gynecological Endoscopy. We are very proud of you, Meenu, for that getting elected on board member. So also she's very active in teaching as a course director of our endoscopic training courses in IIG. Fantastic person, Minu. I think follicular monitoring is, though practically sounds very simple, but I think ultimately the fine tuning in follicular monitoring is going to give you adequate optimized number of oocytes, and ultimately everything comes back and to get that optimized live birth rate in infertility treatment. So that fine tuning is very important. So I think we are really looking forward, Minu, from you to listen to fine tune our skills of follicular monitoring. Over to you, Minu. Thank you very much.
Thank you very much. Thank you, Kundan, for this such a nice introduction. I am really honored to get this introduction from my fellow colleagues, my team POGS member as well, and my at the moment President POGS, acting President POGS in Pune. And it was very nice to listen to the comments of Meera Madam and Gupte sir, and also Parag and Kanchan. You have organized it very well, and you have really put in a lot of hard work, and also Dr. Kiran Sinha, and it was nice to listen to everybody's comments, and everybody is speaking so nicely about you as well, Dr. Kanchan. So we wish you all the best.
Thank you.
With that, and also Manish and Ashish, thank you very much to chair this session. And I shall be starting this talk on ultrasound in infertility and the follicular monitoring. So this is a very nice mixed bag webinar that we are doing. Pune Obstetrics and Gynec Society with Kanpur OBGY Society. I think Dr. Kiran said very rightly that one thing which COVID has done very well is that it has connected us from everywhere, not only in India, but on the globe. So we can be sitting anywhere and can connect with anybody anytime. And especially on Zoom platform, it appears as if we are talking in person. When I was the chairperson of Imaging Science Committee, FOXY, my thing for the 3 years was, the advocacy was that every gynecologist should be able to do a decent pelvic ultrasound. Whether you're doing infertility, whether you're doing obstetrics, patient may come with decreased fetal movement, just put a probe, see how much is the fluid around the fetus. So, at least a decent ultrasound, every gynecologist and obstetrician should be able to do. And that was the reason, as Kundan said, we did many courses, they are still ongoing, on ultrasound monitoring, both in gynecology and in obstetrics. And they kind of became a landmark courses by FOXY for everyone sitting, even in a small corner in a rural area, they could attend these courses. Patient is much more comfortable when she is with her gynecologist as compared to when we send the patient to a radiologist. Half the times they will do an abdominal ultrasound because they themselves are not comfortable doing a vaginal sonography. And of course, patient also is more comfortable with us as compared to with the radiologist, especially for a transvaginal sonography. Time management is much better. Patient may call you in the evening of a Friday and say, the radiologist has said that now the follicle is 18, 19 millimeters. This is the time for you to take the SCG. And then it comes 36 hours later, it is Sunday, and you don't know what to do. So all this damage control, time management, you can do it if you are doing your own scannings. I think how to prepare the vaginal probe, just 2 things I would like to mention. One is the first ultrasound, we do it with full bladder or partially full bladder. So you do an abdominal scan always, because otherwise you sometimes miss on, a fibroid sitting somewhere, because that may not be sometimes seen on a transvaginal sonography. And at least put a hand on the abdomen, because, sometimes I have seen my resident fellows, they don't even put a hand on the abdomen, they straight go for a transvaginal sonography, and she may be having a 24-week size fibroid, which is not even seen on a TVS completely. The second thing is, when we are doing an infertility ultrasound, as far as possible, don't use jelly, just use normal saline. So we keep a syringe with normal saline, we push normal saline, and with the other hand, we place the probe inside so that it doesn't become messy, especially when it is close to the ovulation time and we are planning a timed intercourse for the patient. So what all we see on ultrasound, sometimes we may find very thick endometrial echoes. Again, a very simple thing, we keep an IUI catheter in our OPD, just push little normal saline in the uterine cavity, and here you can see a beautiful fibroid floating here. So you know it is either a fibroid or a polyp, and then accordingly you can plan the management for the patient. And you can also put a color Doppler, and if you have a single vessel supplying to the polyp, then it tells us that when I'm going to do the polypectomy, I must coagulate the base. If I don't coagulate the base, this polyp might reoccur. And your patient will come back to you after 3 months and she will say, Doc, why my polyp has come back? How you had already removed it just 3 months ago. So these small things we should keep in mind when we go for the surgical procedures for these patients. Whenever you find one wall of the uterus thicker than the other wall, unless proved otherwise, just think of adenomyosis. And you may also find small little echogenic areas, small cystic spaces. Take the endomyometrial junction, zoom the endomyometrial junction. And if you find the endomyometrial junction is disrupted, you know that this patient is hard to conceive. So you already have in your mind that what percentage should I give her that she would conceive either with IUI or with IVF. And whenever we are doing a transvaginal sonography, you very clearly see the iliac vessels. Medial to the iliac vessels are the ovaries. There is no tubular structure seen between the iliac vessels and the ovary. Normal tubes are not seen on ultrasound. So if you find a dilated structure, tubular structure between the iliac vessels and the ovary, it has to be a dilated fallopian tube unless proved otherwise. So it can be a hydrosalpinx, pyosalpinx. I will not say, but even my, the younger people also will just tell me, madam, it is an ectopic pregnancy, because we have the PCP and DT thing, so everybody is not actually allowed to do the ultrasound. And of course, fibroids should be matched in a nice way, because when you're taking the patient for surgery for infertility, you must tell the patient how many fibroids you're going to remove. Otherwise, you may have left the fibroid in with a good thinking that it does not need to be removed, and she may go to another doctor, or she may come back with another ultrasound after 3 months, and she may think that you didn't do a good job because you didn't explain to the patient before the surgery. Isthmosil, actually we had 2 days conference only on isthmosil here in Dubai itself. So it's a very big topic. But whenever, for the junior colleagues, whenever you are doing an ultrasound for a patient who has had a previous C-section, even if she's not having any complaints, look for an isthmosil. So if your eyes get tuned to diagnosing isthmosil and a patient comes either with a post-menstrual bleeding, spotting, foul-smelling discharge, secondary infertility, then you will be able to diagnose it much better because you are used to it. Yeah. Then, of course, when the patient comes on day 2 of the ultrasound, then we see these antral follicles over here, number of the follicles that are present on day 2 or day 3, and these are the recruited follicles. Okay, so there are 3 types of follicles in this cycle. One is the recruited follicles, then you will have the selected follicles, and then you will have the dominant follicle. So recruited follicles have been recruited almost a year before. So these are like the soldiers who have been told to fight the battle every month. So they have been recruited, put in the line. Okay, this month, this soldier will go. So these are the recruited follicles. So that is why when I say that I have 4 follicles on each side, this will tell us what is the ovarian reserve of the patient, because these follicles will also tell us what protocol we should use, how are we going to do a follicular monitoring, and for the troubleshooting. So if you look at this diagram here, it takes almost 300 days for these primordial follicles to reach the level of the antral follicles. Another 60 days for the antral follicle to be seen on day 2 or day 3 of the ultrasound. Now, these antral follicles are the recruited follicles. Out of these recruited follicles, you will find 1, 2, or 3 follicles bigger in size. These are the selected follicle, but the selected follicle may not be the dominant follicle. As the time goes by, day 5, day 6, day 7, you will see one follicle which is growing bigger as compared to the other follicles, and that is the dominant follicle. It is very, very important to understand this concept, because if you want to add HMG or gonadotrophins, you must add only when you see the dominant follicle, because that is the follicle which is producing its own FSH. It is also the E2 levels are already high. So if you are not sure whether this follicle is a good follicle or not, do the E2 values. If E2 is more than 50 picogram per ml, that is the time you should start with the HMG or FSH. Don't go by day 7, day 9, day 6. So, all these are also right, but the correct way is to go by the size of the dominant follicle. Even if you have to start estrogen for thin endometrium, again, you should first see the dominant follicle. Once you have the dominant follicle in hand, that is when you should start the estrogen, because by then this follicle is producing its own FSH, and the negative feedback of estrogen will not alter the growth of this follicle. Just excuse me, just 1 minute. Okay. So, so when you look at the follicles, the follicle grows 1 to 2 millimeters per day, and it grows up to 18 to 20 millimeters at the time of ovulation. As this follicle is growing, the other follicles are reducing in size. Now, we have many IVF patients who may come and ask, Doctor, I did 2 IVF cycles outside. They removed 12 oocytes each time. This time you have taken out 10 oocytes. Are you depleting my ovarian reserve by doing these IVF cycles for me? So we have to tell the patient, okay, you have to show this diagram that every month these follicles are recruited for you, out of which only one follicle will form an egg and others will undergo atresia. So what we are doing is we are giving extra food to the follicle so that all the follicles come up, and we are not reducing your ovarian reserve in any kind of a way. So as the follicle is growing, you can see these are the pre-ovulatory changes. You will see a cumulus, you will see a sonolucent halo, infolding of the follicular wall. At the same time, you will find the secretory changes. Now, what is the advantage? Clinically, what will you do at this time? We can do a urine LH test for the patient. Now, if her urine LH is positive, that means she is already close to the ovulation. And if we have to do the IUI for this patient, we should do the IUI the next day or today, and not wait for 36 hours. Shh. Just close the door. Okay, and not wait for 36 hours. So this is important to understand. If it is an impending ovulation, if it is a pre-ovulatory, if LH is positive 24 hours, just pre-ovulatory, you should do it today, and otherwise you can give HCG, wait for 36 hours, and then do the IUI. So what happens at the time of ovulation? One thing we commonly, all of us deal with in our practice, that doctor, my follicle does not rupture. But what happens, why it is not rupturing? 2 things. One is this follicle which is forming and it is ovulating. It is not an event. Okay, it is a process. So it is not that you saw the follicle yesterday and today this follicle will not be there. It only shrinks in size with some echogenic areas in the follicle and some free fluid around the ovary, around the follicle, as well as in the pouch of Douglas. So if you see fluid in the pouch of Douglas, if you see little irregular margins of the follicle, if you have already checked the vascularity and now you see the vascularity is more focal, and you see you do LH and LH is positive. So all this will tell you that the ovulation has occurred. So don't go by just the size of the follicle that you are seeing. This is a day 21 ultrasound. You can see over here, it is a thick secretory endometrium. This is a corpus luteum. This is how the follicle becomes slowly. It does not disappear. It becomes into corpus luteum. So if a patient comes to me on day 21, for example, and I do the ultrasound, at least I know that she does not have any ovulation disorders. Now, how do we correlate the endometrium with, when we are looking at the follicle size, we are also looking at the endometrium at all times. That is very, very important. Endometrium also grows by 1 to 2 millimeters per day. And just before the ovulation, you will find the endometrium, or just at the time of ovulation, when you have the LH surge, you will find the endometrium is showing peripheral echogenicity area. So if you see it in a transverse view, you will find a ring-like structure, and it is also called a ring sign. Also important to grade the endometrium, see how much is the thickness of the endometrium, pattern of the endometrium. This is a grade A endometrium, this is a grade B endometrium, and this is a grade C endometrium. So once you have seen the endometrium, you can cancel the patient. That is very, very important. Whether you're doing IUI, IVF, if you don't have a good endometrial lining, then at least it has a very good negative predictive value. So you look at the vascularity zones, and if you do not find blood flow going into the myoendometrial junction, you know that this patient has very low chances of conceiving. Sometimes you get a pregnancy with a thin endometrium with not so good the pattern of the endometrium, and you are very happy, oh my God, it was only 5 mm, I got the pregnancy. But we should not celebrate very early, because these are the patients who have a very high risk of first trimester losses, because the endometrium is not so good. So that we have to keep in mind. This, I think I can skip it little bit. I can skip. So a bit of troubleshooting. Sometimes we may find a large follicle. Day 7, there is a 20 mm follicle. What to do? Is it the dominant follicle? Is it the selected follicle? Or it is just a nuisance value follicle? Put the color Doppler, and it probably will not have a good blood supply. You do the E2 values, and E2 values are not corresponding to a big mature follicle. Any mature follicle will give you the E2 values of 150 to 200 picogram per ml. And you have a E2 of only 60 picogram per ml. And you have a small follicle which is lying next to it, which is 14 mm size follicle. So you forget this follicle, you follow the 14 millimeter size follicle, and you give gonadotropins if you have to, as per that follicle, also the SCG, and you can forget about this follicle. Sometimes Pune, I mean, we have so many people from Pune, we know that it's being an IT capital of the country, we have a lot of IT couples. So they have already done a PhD in infertility before they come and see us. So they do their own LH test at home. When LH is positive, they know that it is a time, which is nothing wrong in that. I mean, they can definitely do that. But when they don't conceive, they come to us. And what happens in these patients, sometimes, especially patients with endometriosis PID, when you do the ultrasound, what do you see? You find that there is no rupture of the follicle happening. There is no free fluid in the pouch of Douglas. However, there is some echogenic areas in the follicle. There is some free fluid around the ovary, and the endometrium is becoming secretory. So these are the luteinized unruptured follicles. Okay, so they are luteinized. LH is positive. If you do the progesterone, will come positive, but they are unruptured follicles. So what we have to do in such patients, in the subsequent cycle, once you see a dominant follicle of 14 to 15 mm in size, that is the time we add antagonist. Once we give antagonist, the LH is suppressed. Okay, but antagonist will also suppress the FSH. So along with the antagonist, we also need to give gonadotrophins for this follicle to grow. So 1 or 2 days of antagonist with gonadotrophins followed by a trigger with SCG, you will get wonderful pregnancies in IUI in cases where you are having either a luteinized unruptured follicle and sometimes also in unexplained infertility. PCO patients, again, sometimes they are difficult to stimulate. So what we do is you go for a chronic slow dose gonadotrophins for them. So we start with 37.5 from day 2. First thing is whenever they come, put them on either metformin or some inositol with metformin combination. First thing when the patient sees you. Then from day 2, of course, you have already tried letrozole. She did not respond. So we can go for the gonadotrophin. So 37.5 from day 2, give it for 5 days. After 5 days, we do the ultrasound. If you find a single dominant follicle, continue with the same dose. If not, then increase the dose to 75. Again, wait for 5 days and repeat the ultrasound after 5 days. Most of the times we can manage only with ultrasound. Sometimes if you are not sure, you can always do the E2 values, and that can guide you as to what dose that you continue with and whether you should increase the dose or not. And once you see the follicle about 18 to 20, and then you can give the trigger with ACG. Poor responders, sometimes you find a follicle coming up on day 3, day 4, because their FSH levels are high. So in those patients, again for IUI, we can give 2 or 3 days of antagonist. So on day 2, day 3, or day 4, you give antagonist, suppress the FSH and LH level. And also in PCO patients, you can do, because LH is high in those patients. There also for IVF patients, many a times we give antagonist in the first 3 days, and then you start the stimulation in these patients, and they do pretty well, better than they would have done otherwise. So how to measure the follicle size? Always you can do with 2D, no need to have a 3D for the follicle measurement, and take on always in 2 dimensions. Second one crossing in the center of the first measurement, and then you take an average of the 2. Most of the ultrasound machine, they are with AI, and they already show you the the average of the follicles. Whenever excuse me, whenever you are in doubt, put a color Doppler. If it is a mature follicle, it will have a vascularity of 3/4 of the follicle. If you're not seeing good vascularity, you are in doubt, then do the E2 values. As I said, a mature follicle will have 150 to 200 picogram of E2. If your E2 is not matching with the size of the follicle, your color Doppler is not showing good follicle, it does not have a good surface tension, it is looking little collapsed. So it is better to cancel the cycle, whether we are doing IUI or IVF. So these 3 things we should learn during follicular monitoring. One is, as I said, atretic dominant follicle, which is a selected follicle, but not a dominant follicle. It should be just nuisance value. It should be left behind. Anovulatory luteinized dominant follicle, which is unruptured luteinized follicle. Again, here I have already explained you the role of antagonist, and the third is a normal ovulatory dominant follicle. So if you can distinguish between these 3, I am not talking too much about the thin endometrium, because I don't want to, that's another full lecture on ultrasound monitoring, what to do if the endometrium is thin. So since it is on more on follicular monitoring, I will not talk about it. However, if we have any questions on thin endometrium, we can definitely take it up. So role of antagonist, both follicular and endometrial monitoring. What is the role of E2? How do we troubleshoot, and how do we time the IUI? So we must know in when we are taking the patients either for IUI or even for an advanced treatment for ART. So thank you very much. Thank you, Kanchan, for giving me this opportunity to speak. Thank you so much.
Thank you, Dr. Meenu, for that excellent brief overview about follicular monitoring. Ideally, I am supposed to summarize, but you have nicely explained it. So I will just say a few words about it, that, Dr. Meenu has not only given us how to measure the follicles, But at the same time, she has nicely explained those important factors which will always give us the prognosis of the cycle outcome also, like perifollicular growth, endometrial picture, all those things, documentation of, kind of whether the ovulation has perfectly happened or no. I think that was a brilliant lecture, Dr. Meenu. And I think the purpose of understanding follicular monitoring phase, I think you have done a really excellent job. So if there are any questions, Dr. Kanchan, we can take it now. I guess.
Really, this was a wonderful talk, Dr. Meenu. I really appreciated your talk because I'm also an infertility specialist, but you really wonderfully explained each and everything very nicely. Thank you for being here. And I think the questions, there are no questions in the
couple of
chat box.
questions. I don't see any questions in the chat box till now, but one question is that, during follicular monitoring, what kind of cutoff in terms of number of follicles or size of follicles you follow to say that there are higher chances of OHSN and I will cancel the cycle? So what do you follow in your practice?
See, this has to be actually done before we stimulate the patient. So we select the patients who probably might go in for a OHSS. Though those patients are taken on an antagonist protocol and they are given agonist trigger with freeze-all. So actually it does not matter. However, if the E2 values are more than 3,500, if you see more than 18 follicles in total, then you have a higher risk of OHSS, and these patients should not be given SCG trigger and should go for agonist trigger with freeze-all policy. Yeah. Thank you.
Okay, now this was related to IVF, but what about treatment like simpler treatment, which are common like IUI, where your intention is to have 2 or 3 follicles, but when do you decide that, okay, I will stop this cycle?
Got it. See, sometimes I think all of us get calls from our colleagues saying that I was stimulating this patient for IUI, but now I see 4 follicles on each side, all are 15 mm, 16 mm in size. What do I do? You do the E2 values, E2 is say 1200 or 1400 picogram per ml. So these are the patients, either you can convert them to IVF, that is one option. Second option is, of course, to cancel the cycle. Third thing which we have done, but we have not published. So what we are doing is we actually take them another 2 days, give HCG trigger, go for the pickup, and we just leave 2 follicles behind and do the IUI. But we discard those follicles. So, but we don't have the publication, so I will not promote it. Another thing what we can do is, if we have cancelled the cycle, what do we mean by cancel the cycle? This is for the junior colleagues. That does not mean that we tell the patient, okay, don't have intercourse and you might go into OHSS. We have to make sure, because she will still have an SCG, she will still have a SCG trigger on her own. Even if we don't give her SCG, she can still have a LS surge. So we have to put her on antagonist. That is very important to suppress the naturally occurring LS surge. So 3 or 4 days of antagonist and give her progesterone. So just 5 days or 7 days of progesterone, make the luteal phase very short. And so once she gets her periods, your fear of OHSS will go. So these 2-3 things we have to keep in mind. Along with, you can give albumin, you can give high protein diet, you can do PCV every day. You can also call her maybe daily sometimes to see any distension in the abdomen, see how much urine she is passing. Just look for any basal creps. So all those things also you can definitely see. But very important is to add antagonist. Cancel the cycle and add antagonist when you cancel. Cancelling,
that's very important.
She can still have a natural LS surge. Yeah.
That's very important, that giving agonist, you can avoid OHSS, but you cannot prevent multiple pregnancy risks. So I think it's very important to handle and keep it in mind both the complications of ovarian stimulation. So with that, I think thank you, Meenu, for that wonderful presentation once again. And I hope you are enjoying your Dubai trip and your training sessions also.
Too much work.
Thank you. All the best. Happy journey. Just come back safely from there to.
Thank you. All the best. Wish you all the best. Thank you.
Thank you.
Hello, Charu. Thank you.
Really a perfect talk. Now may we proceed to other session. I think the other session is mine, NCD and its disease burden, and the chairperson are Dr. Nilesh, Dr. Kalpana Dikshit, and Dr. Kiran Sinha. And speaking to Dr. Nilesh, he is very intelligent obstetrician, and he is a chairperson of a quiz committee, and he's an obstetrician, gynecologist, and infertility specialist. Have a 19 years of experience overall. He is a clinical head and fertility specialist at Oasis Fertility Pune. He has handled successfully more than 1,000 successful cases of operative laparoscopy and 2,500 cases of diagnostic and operative hysteroscopy. I have heard his quiz session. They are wonderful always. He is a faculty at the reproductive medicine by university क्या है of SH Germany. He was invited to deliver guest lectures at the various national and international conferences. Welcome, Dr. Nilesh. And Dr. Kalpana Dikshit, very lovable person. I like you, Dr. Kalpana Dikshit. She is very pleasant personality and was organizing secretary of this national conference along with me, and she has a very good vision. She is the director of the Jeevani Hospital and at present the vice president of KOGS, and she is a master trainer of GDM Foxy 2019 and got many awards in her feather. Welcome, Kalpana, dear Kalpana. And next chairperson is Dr. Kiran Sinha. She is the past secretary of my society, at present the secretary of ISOPAR, and she's a senior consultant obstetrician and gynecologist of the Kanpur, and she is retired from PMHS, and most think she is a very good human being, always have a great courage to do all the things. We learn many things from her, and usually even for we have a academic forum at our own Kanpur, and she is always in touch with all these academic activities and put all of us in many effort. And your efforts in the national conference was appreciable, madam. We welcome you. And the mic is yours. Yes, mic is yours.
Thank you, Doctor, my dear Kanchan, for making me a part of this prestigious webinar. Dr. Kanchan, now I think is not a new name. Most of us know about you. So no need to elaborate your full introduction. Few lines about you, I must say, as it is customary and respect to the speaker, I will definitely go about it. At present, Dr. Kanchan is Secretary of Kanpur Obs and Gynae Society. She is very humble, gentle and laborious secretary. She is contesting for the post of Chairperson NCD Committee, going to be held in coming August. So I will request all the secretaries and president to please vote for her. Why I am saying this, as she is the fit person for this committee, leading a very healthy lifestyle. She does meditation, yoga, morning and evening walk daily, and takes full care of her diet. So I think most fit candidate for this committee. And few lines for the introduction of the subject. NCD means non-communicable disease, which is not caused by infection, but it is chronic and disease of long duration, which progresses slowly but has a great adverse effect on your life. And the four most common NCDs are CVS, cancers, chronic respiratory diseases, and diabetes. And most common factors are tobacco use, unhealthy diet, physical inactivity, alcohol and air pollution. And the best part is that most of these are in our control. So to talk about NCDs is very important, and I think this is the reason that FOGSI has a separate subcommittee with the name of NCD committee, for which Kanchan is contesting for this committee as a chairperson. Now, not taking much of your time, I invite Kanchan for you talk. Dr.
Thank
Kanchan, please
you.
go ahead.
Thank you, madam, for your blessings and good wishes. My sincere regards. Now, should I share the screen?
Yes. Yes, Kanchan.
Yes, I'm sharing the screen. So, NCD, talking about the NCD and the lifestyle and the meditation. NCD is, just I want to change the slide. Is a non-communicable diseases. These are now defining problem of 21st century with an estimated economic loss of $7 million US, especially in the low and the middle economic countries. By 2025, NCDs are expected to cause 7 out of 10 deaths in developing countries. Such a high incidence. So we have quite high challenge and have to focus on it. So therefore, I have kept today's CME. Talking about the non-communicable diseases. These, as I have picturized in this particular diagram, these are diabetes, cancer, chronic lung diseases, heart disease and stroke, mental illness, physical inactivity, smoking, unhealthy diet, and there are many other unhealthy diet, and few others are also included in these NCDs. So while defining the NCDs, NCDs is a medical condition or the disease which is not infectious, which are generally chronic in nature and have relatively slow progression. They are not transmitted from one person to another by any agent or agency. Non-communicable diseases are a defining problem of the 21st century with an estimated economic loss of $7 trillion US, especially in low and the middle economic countries between 2011 to 2025. So by 2025, NCDs are expected to cause 7 out of every 10 deaths in developing countries. This challenge raises many questions, including how to raise the priority of the NCD on the national policy agendas and augment the capacity and identify resources to overcome it. Now coming on, what are the types of NCDs? Cardiovascular diseases, example coronary heart disease, stroke, hypertension, cancer, chronic respiratory diseases, diabetes, mental illness, account for majority of the deaths and disability. This is a WHO data. So 1 in 3 deaths in the women are from the cardiovascular diseases and the stroke, as is shown in the diagram, are by the cancer, by the chronic respiratory diseases, by the diabetes, by the mental illness, and other NCDs. So why NCDs are important public health problem? Because NCDs are a major public health problem because 41 million deaths per year were there. They are increased to 52 million deaths per year, which are expected. Economic impact and the health budget is there, which is affected. These NCDs, they cause the global burden. They kill 38 million people each year. Almost 80% of the deaths that is 28 million, occur in low and middle economic income country, and 16 million NCD deaths occur before the age of 70. So we should work on it. Cardiovascular diseases, if we say they account for most, they are 40% of death by this cardiovascular diseases, and 4 groups of diseases account for 82% of all NCD deaths. Tobacco use, which we see in our country, is most. Even the small children I have seen, they are chewing tobacco. Many ladies which come to us, they are chewing tobacco. Physical inactivity, the harmful use of alcohol and unhealthy diet all increase the risk of dying from non-communicable diseases. They all come under non-communicable diseases. So this figure that represent, this yellow is by the cancer, blue is the cardiovascular diseases, and this orange is the chronic respiratory diseases. You see, again, the same thing is represented, that maximum deaths are by the cardiovascular diseases, then the cancer, and then comes the chronic respiratory diseases. So this is again a bar diagram which represents that in the female deaths, there are so many deaths by the non-communicable diseases. This pink color represents non-communicable diseases. This is again a graph which show that maximum mortality is by the cardiovascular diseases. This pink is by the cardiovascular, represent the cardiovascular diseases. Again, if we rank 10 selected risk factor for the cause of death, the maximum comes to be raised blood pressure and the heart disease. Then the tobacco, high blood glucose, physical inactivity, overweight, high cholesterol, unsafe sex, alcohol use, child underweight, and indoor smoke from the solid fuel. So this is again a diagrammatic representation of the risk factor. See, high blood pressure, tobacco use, alcohol, raised blood sugar, decreased vegetable and fruit intake, that is the faulty diet, raised cholesterol, obesity, and physical inactivity, which most commonly we see in IT industry. And nowadays, most of the children, they work from home and they keep on sitting for long in the computer, and they suffer from all maximum NCDs. So there are many risk factors. These may be modifiable or the non-modifiable for the NCDs. Non-modifiable risk factors are age, gender, family history, ethnicity, and prior stroke or the heart attack. While modifiable risk factors are unhealthy diet, high blood sugar level, smoking, high blood pressure, high cholesterol, physical inactivity, overweight, excessive alcohol, and stress. These all can be controlled by the efforts. So modifiable behavioral risk factors, amongst this, tobacco accounts for around 6 million deaths every year and is projected to increase to 8 million by 2030. More than half of 3.3 million annual deaths from the harmful drinking are there, about 3.2 million deaths annually can be attributed to insufficient physical activity. This insufficient physical activity we see in many population, because usually the children, they don't get up from the bed late till in the morning, and they sleep late in the nights, and they physical activity. In 2010, 1.7 million deaths from CVS have been attributed to excess salt and the sodium intake. These risk factors go on accumulating, starting from in utero life to childhood, adulthood, and the midlife. So they have a cumulative effect. They should be controlled at each and every step. So prevention and the control of NCDs That is the WHO response. Our government and the WHO has taken many steps to control this. In 2011, under the banner of WHO, more than 190 countries, they agreed to reduce the NCD burden, including a global action plan for the prevention and control of NCD. This plan aimed to reduce the number of premature deaths from NCD by 25% by 2025 through the voluntary global targets. What are these targets? These targets will focus on addressing the main risk factors such as the tobacco use, harmful use of alcohol, unhealthy diet, and the physical inactivity. The UN General Assembly will convene a third high-level meeting on the NCD in 2018 to take stock of progress in attaining the global target by 2025. First Global Ministerial Conference on Healthy Lifestyle and Non-Communicable Diseases Control that held in 28 to 29 April 2011 in Moscow. What was the aim of this conference? Was to support member state development, develop and strengthen the policies and programs on healthy lifestyle and NCD prevention. The conference had three main goals. First one was to highlight the magnitude and the socio-economic impact of NCDs. And second was to review the international experience on NCD prevention and control. And third was to provide evidence on the pressing need to strengthen global and the national initiative to prevent NCDs as the part of national health plans and sustainable developmental framework. They want to keep these NCDs as a part of national health program. Therefore, they have brought certain health program. If we talk about the parameters, the current daily tobacco smoking, the population aged from 15 or older who smoke tobacco on a daily basis, they come under high risk. The physical inactivity, if we talk, the percentage of population aged 15 or older engaging less than 30 minutes the moderate activity per week or less than 20 minutes of the vigorous activity 3 times per week were equivalent. Raised blood pressure, if we talk, the percentage of population aged 25 or older having systolic blood pressure of equal to or more than 140 and diastolic pressure equal to or more than 90. They included under high risk category. In the same way, raised blood pressure, if it was 25 or older, having a fasting blood glucose values of more than 126 milligram per dl or on medication for raised blood glucose, if they are overweighted, equal to or more than 25 kg per meter square, they are obese, the percentage of population aged 20 or more older have a body BMI of more than 30 or equal to 30 kilogram per meter square. These all are under high risk. And moreover, if the raised cholesterol, which is again more than or equal to 190 milligram per dl, that again come to under high risk. So millions of deaths can be prevented by stronger implication of the measures that exist together. There are lot many anti-tobacco control programs by the government. The programs were also for promoting healthier diet, physical activity, and reducing harmful use of alcohol, along with improving people's access to essential health care. This was the Indian scenario that National Health Mission, and there are so many things. Ministry of the Family Welfare, they planned many programs. These include under these program, they are known as the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. If we go and see their register, they have these all programs: National Program for Control of Blindness and Visual Impairment, national, because all the NGOs, they can do and work under this program: National Mental Health Program, National Program for Health of Elderly and Prevention of Control of Deafness, National Tobacco Control Program is there in their register, National Oral Health Program is there, and National Program for Palliative Care, National Program for Prevention and Management of the Burn Injuries, and other non-communicable disease control program. So many of the NGOs are working under these programs. These jointly are known as NPCDCS. So what are the objective of these NPCDCS? They prevent and control the common NCDs through behavior and the lifestyle changes. They provide early diagnosis and management of common NCDs. They build capacity and the various level of health care for prevention, diagnosis and treatment of common NCDs. They train human resource to cope with the increasing burden of NCDs and establish and develop capacity for palliative and rehabilitative care. So in summary, I have kept this talk in a very short, just what is NCD and telling about what are the government plan and what are the government plans and strategies doing about it. So in summary, the non-communicable diseases are now the most common cause of death worldwide, increasing rate in low and the middle income countries because of change in lifestyle, that is urbanization. So key risk factors have very large effect. Interventions are effective and can reduce burden. The need to combine results and have large studies are still there. So what is the take home message? That we should all try to lead the healthy life and reduce the tobacco use. Physical inactivity should be discouraged. Harmful use of alcohol should be discouraged so that we can reduce all these diseases. Thank you very much. We should exercise regularly, eat healthy diet, reduce the stress. And thanks and gratitude for your blessings. Thank you very much. Thanks to chairpersons and all the faculty.
Is there third chairperson is there or not? I couldn't see here. Kanchan?
Dr. Nilesh?
Is he there?
Madam, you can sum up. You can sum up.
Kanchan, you have very beautifully told everything. Actually, everybody knows everything. लेकिन कहीं ना कहीं आलस रह जाता, आज करेंगे, कल करेंगे, परसों करेंगे. Some there are some factors which we cannot change as age and the race and everything, but there are so many factors which we definitely can follow in our life by healthy lifestyle management, good diet and everything. But it is a continuous process. It is not just like a day, matter of day or two. You just do a day, do 1 a day or 3 and everything will be all right. Actually, as we all know, these diseases, they are being inherited by the mother when the fetus is in the womb. Because that is why these days we always say, you just reduce your weight first and then plan for the delivery. Then now we have to do the things and all the efforts when the baby is inside the uterus. कहते हैं ना, जवानी भी जीने के लिए बचपन में जीना पड़ता है और बुढ़ापे में जीने के लिए जवानी में जीना पड़ता है. तो इसलिए this is a continuous process. Everybody, at least every doctor knows everything, but I am very, very sure and very sorry to say even that hardly 40% of the doctors, they regularly follow a good diet and a healthy lifestyle. If I am wrong, kindly excuse me for that, but this is my vision that I could see that. Because whenever I go to any meeting, everything, then I see the food there and everything, and how the people they eat there. So sometimes I really feel very bad being a doctor if we cannot say anything. देखो जब पेशेंट आता है ना, अगर आपका वेट 100 किलो है, आप इनफर्टिलिटी पेशेंट आया, आप उससे कहो कि एज अपना वेट कम करो, तो वो तो पेशेंट खुद ही सोचेगा, खुद तो इतनी मोटी बैठी, हमसे कह रही वेट कम करो. So before saying anything, you have to follow all these lifestyle yourself. Only then it is going to affect your patients also. So we have to start everything from ourselves. Only then we can communicate anything to the society. As far as the air pollution is concerned, first हमको पहले अपने को प्लास्टिक का झोला बंद करना चाहिए, प्लास्टिक नहीं लेना चाहिए. अगर if we will do this thing, naturally we can say to others also कि please don't use this thing. But I think not even a 1% of people they are following it. Even then, everybody knows about it. Kanchan, your talk is really very good, and we should also all follow about your guidelines which you told today. Thank you so much.
Thank you, madam, for your nice words. And you rightly said that devotion is not a mysterious gift. It cannot be cultivated by it can be cultivated only by the regular effort. And these elimination of NCDs, they need a great effort and devotion. Now coming on the next talk, very important talk by Dr. Sunita, madam. And the chairperson for this is
Dr. Kanchan.
Ji, madam.
Dr. Sunita had just called. She told me that she is getting a little delayed and occupied, so she's requested us to take the panel first.
Okay, madam. That is so Dr. Girja Wag, madam, and Dr. Chaitanya, they are the moderator for the next panel, and our panel is a very good panel. That is a panel on high risk pregnancy. And the moderator are Dr. Girja Wag and Dr. Chaitanya. And telling about the Dr. Girja Wag, madam. Madam, you are the
Kanchan. I will skip this because we've already know each other quite well, and it's important that we get the academic things ahead. All are waiting for that.
True.
What do you say?
Okay, thank you, madam. But just एक दो line just back Sahiti. थोड़ी सी you are the Foxy Vice President elect and Professor and HOD Department of OBGYN, Bharati Vidyapeeth Medical College and Hospital Pune, and you share so many awards in your feather, and we always appreciate your lectures and panel. So you are most welcome. About the Chaitanya, Dr. Chaitanya, he's very good human being, as I have talked to him.
Madam, you can just say that I'm the national coordinator for endocrinology committee. That's all.
National coordinator for endocrinology committee, and my good wishes to him for the coming as a chairperson of the endocrinology.
Kanchan, both of them, they are very good moderator. We don't want even to miss a single sentence of Dr. Girja Wag and Dr. Chaitanya. So please don't waste the time in the introduction and just go ahead.
Yeah.
Agreed to you, Madam Kiran Sinha.
Agreed, absolutely agreed, madam.
Always listen to the seniors.
Yeah.
Yes. So Baki, Dr. Ashwini Kale as an expert.
Yeah, I think if you
now
can
you will introduce all the moderators.
Share the slides.
Yes.
Yeah.
My program is ready.
Madam, will you introduce all the panelists? Dr. Ketki, she is a professor and HOD, SKN Medical College, Pune.
Yeah.
Dr. Mangla, past clinical secretary, POGS. Dr. Archana, treasurer of POGS. Welcome you. Dr. Sangeeta Arya, she's a Joint Secretary, KOGS, our own society. Dr. Kavita has not joined. Dr. Richa Valla, she's the executive member of our KOGS. Welcome all the panelists. And the mic
Kavita is not coming, madam.
Dr. Kavita is not coming. Dr.
Okay, so
Shali
Dr.
Agarwal, she is
Mangala
a Joint Secretary.
Dr.
KOGS.
Mangala is also not coming because she has an appointment with the UK embassy. So she just messaged me. And Dr. Uma Wankhede madam is there. She is professor at Government Medical College, Baramati.
Thank you.
So, welcome all the brilliant panelists, and mic is to the moderators. Madam, mic आपके पास है, आप moderate
हाँ, मैडम शेयर करेंगी स्क्रीन.
Rahul, you have the other dongle ready, no?
Are you able to see the screen?
Yes, ma'am.
Yes, madam. Screen is visible. Yeah, just need to go on the slideshow.
Slideshow?
Yeah, that's it. Perfect.
It's on the slideshow now?
Yes, ma'am.
Yes, ma'am.
Okay. So, welcome to this panel, and without much ado, I would like to thank Dr. Kalpana for inviting me and Dr. Chaitanya here as moderators for this wonderful panel on high-risk pregnancy, and they are definitely
Kanchan, madam.
Pardon? Kanchan.
Kanchan.
Yeah, sorry. So we have Dr. Ashwini Kare as an expert, but I didn't see her, but all the same, with due respects to all the panelists, and we have Dr. Ketki, Dr. Uma Madam, Dr. Archana from Pune, Dr. Mangala is not there, and Dr. Sangeeta, Dr. Richa, and Dr. Shaili from KOGS Society. And I'm sure we are going to have a wonderful discussion. And this is going to be consisting of 3 case minutes, each for 12 minutes, with crisp conclusions and take-home messages with proxy checklist to conclude. So quickly coming to Mrs. Astor, who is 22 years, 32 weeks pregnant, gravida 3 with 2 miscarriages, has come to us with breathlessness, abdominal discomfort, history of anemia always between 9 to 10 grams per deciliter, once had 7 grams in teens, corrected with oral iron for 3 months, suffers from chelosis, gastritis, glossitis on and off, and workup. क्या करना है उनका? Any other supplements or anything? So this particular has been always been given treatment for iron and keeps on tolerating, not tolerating. But now today, she has come at 32 weeks with abdominal discomfort. And on examination, we can see that she has tachycardia, blood pressure is 90/70, oxygen saturation is 95, has rhonchi, is coughing for 7 days with yellow expectoration for 2 days, feels feverish and tired, has a soft systolic murmur, no signs suggestive of failure. Uterofundic height is 28 centimeters, external enlargement, plus single fetal cephalic, fetal heart rate 156 beats per minute, and per speculum PV not remarkable. So Dr. Sangeeta Arya, what's the workup that you would suggest in this patient now that she has come to us? This is the case history.
Very good evening to all the respected seniors here. Here, as such, you have given us the case. I am the house surgeon. I am happy to be the JR1 here to deal with this case first. So, इसमें what the catchy points here you have given is that she has always been anemic. She is at 32 weeks, come with a as such history, but the like history is being clinical scenario seems to be like of anemia in this patient. But the other thing is she has clear cut lung infection along with having a subclinical fever also, and she is having abdominal discomfort, so she may be case of preterm labor. Here when I am putting the Vigo in this patient and managing for the other things, I'll be sending, as you have asked for the investigation, I'll be sending for the CBC of this patient. Along with CBC, we don't forget to send for the peripheral blood smear, as well as the patient is giving history of routine earlier anemia also, I'll be sending for the serum ferritin levels in this patient, as well as the peripheral blood smear test, as I have already told. The CBC and the peripheral blood smear will be, after seeing this, we will be able to find out what kind of anemia is that there, and in the PBS there is some pencil cells are there, target cells are there, some kind of sickle cell are there, or type of anemia we can rule out. The other thing I'll be doing for this patient, if earlier not been sent, is the urine routine microscopic and culture, as well as the LFTs, KFTs. The blood sugar of the patient, sometimes the diabetic patient in ketoacidosis usually do present with these kind of things. And the other, the patient is already having fever and patient may land up in preterm labor. I'll be sending the CRP of this patient to, as well as if the patient's condition is poor, I'll be sending for the arterial blood gas analysis of this patient. My TB chest person comes, they can do the spirometry of this patient, and if we have to rule out the infection of the chest, which kind of infection she is having, we can do the sputum culture of this patient. And the second patient is the baby. For the baby, I'll be doing the USG scan for the baby's condition to rule out IUGR, low birth weight baby and all. Along with the cervical length, we should not forget, because she may land up in preterm labor also. These investigation I'll be going for.
Thank you so much, Dr. Sangeeta, for giving us a wonderful insight and elaborating all these things so well. I don't know why the slide is not moving next. Okay. So Dr. Ketki, does she need to be on the Muse chart monitoring? Yes, no, why? And can you just tell us what is the Muse chart?
Well, this Muse chart was devised to find out it's a modified obstetric early warning chart. And it was initially devised for monitoring of the post-op patients, but later on it was used for all women or all patients who need monitoring for detection of early signs, which may detect for whether the patient is deteriorating. So here the staff nurse will be monitoring the patients, and it will be mainly monitoring for the SpO2, the respiratory rate, the other vitals like pulse, blood pressure, the diastolic blood pressure, evidence of the urine output, evidence of any alert signs, the score, the VIP score, and whether there is any discharge and abdominal pain. And if the score remains 0, then the patient will be kept under monitoring. But if the score is deteriorating, it becomes 1 to 4, then further information or the staff nurse should inform the residents. And if it goes more than 5 or any of the 3 number is reached, then further workup is needed by the lecturer, whether some decision making or change in the management can be decided. And this is to prevent from deterioration of the patient, so that early.
Here, we can ask the audience here, how many of you that it will help us in risk stratification at the outset itself, and also help us in assessing the deterioration of the patient. And today, when we are looking at all the Manyata Laksha accreditation and the NABH accreditation, hospital care requires, it mandates that everywhere where there's a birthing facility, and if you have a high-risk patient coming to us, it's important that you put her on this Muse chart. Thank you so much, Ketki. Now, since Ketki, you have also 2 more responsibilities.
Madam, can't hear.
You are not audible in between, madam.
Yes, is it okay?
Yeah.
Yes.
Any immediate treatment you would like to give this patient? Would you want to give her any immediate treatment? Ketki. Or anybody on the panel can.
The patient's SpO2.
I will, Girija.
Yes, madam.
Yeah, she's 32 weeks with anemia, with LRTI, with maybe IUGR. So I'll admit this patient first. And once she's indoor, I will start her on IV antibiotic, depending on the hospital. I will start antibiotic and send the culture of the sputum. Later on, change it if required. And symptomatic management, oxygen, physician referral. And as you said, ideally we should do the mu score and find out if she's in the early mu score, the intermediate or the late mu score, and accordingly treat her. And of course,
Madam, would you want to admit this patient? Would you want to admit this patient?
Yeah, I will admit. I will admit.
Definitely.
I think all of us would agree that this patient requires admission.
Yes,
Now,
yes.
Uma madam
Admission.
and Kate, between you can decide to answer this, of course. The reports of the patient have come. Somebody is disturbing. Can you just avoid that disturbance? Maybe, please. Yeah. इसका तो double machine होगा. I don't know, some disturbance is there. Please watch your disturbances. Okay. So the reports have come. Anybody would like to comment on this? Complete. You can see the reports are obviously seen here. 7.4 CBC, PCV 33, MCV 79, RDW 21 platelets, TLC 13,500. Neutrophilia is seen 78%. Serum ferritin is 335. Because Ketki had told us in the beginning, Kavita had said that we will be taking the serum ferritin. And then, not Kavita, I'm sorry, Sangeeta madam had said, urine pus cells 7 to 8 high paraphils, ketones 1 plus, proteins 1 plus, glucose absent. Would Uma madam, would you like to comment on this?
Yes, she has anemia. The anemia is moderate anemia. She has a low PCV. She has iron deficiency anemia, but her ferritin is not low; it is high. And she has infection. Her TLC is 13,500. She has a urinary tract infection, and she looks dehydrated. That's why mostly her ketones are positive and glucose is absent.
Yeah, and glucose absent, I think, gives us a clue that she's not a diabetic to top it all, which is what we have to look into. And would you want to comment on the RDW, madam? Because I think, it is our poor man's quick assessment of something better, because she had an antecedent history of anemia all the time.
Yeah, like one of the most important DD of a microcytic hemoglobin anemia is iron deficiency versus thalassemia. So instead of doing hemoglobin electrophoresis, etc., RBC bit more than 19 if you get, it means it's iron deficiency anemia rather than thalassemia.
Yes. Thank you so much, Dr. Uma. Your experience really helps us, and Uma has always even taught us, and we are very proud to have you here, Uma madam, to guide us always. And now coming to Dr. Richa Bhalla. We are technologists, and I think all of us have become experts in anemia in India as a country. So what would you suggest whenever once you've done an initial CBC and you see that these patients' reports have already been done? So what should be the next approach, and how should you be approaching the anemia component of her and the evaluation? If you could just tell us.
So after a detailed history and examination, and mostly towards the cause of this anemia, we would like to investigate the patient, and for that an initial complete blood picture is important, along with the peripheral blood smear, which is going to tell us about the degree and the type of anemia definitely. And once we diagnose that it is iron deficiency anemia, we must go for the iron studies like serum iron, which is usually less than 30 microgram per 100 ml, total iron binding capacity, which is usually more than 400. Serum ferritin is definitely an important indicator. Then in case we don't find that the patient is anemic, then we should repeat the complete blood counts at 24 weeks and subsequently in the second trimester. And
again, so you, in this particular patient now, this should have been done during her antenatal care. You'll advise. The reason why we put this up. Can you hear me now? Hello, can you hear me?
Yes.
So the reason we put this up is it's very important that at various timelines in the first and the second and the third trimester that hemoglobin is done. It should not be just done at one time and forgotten, because it can keep on evolving, and especially if a patient has a chronic history of anemia, we have to be careful. And that was a wonderful message that you gave us, Dr. Richa, that PBS is very important, and you'll also not only rely on serum ferritin, but we'll also do the full iron studies. coming to Uma madam, what would be now the approach to Aster, especially when her hemoglobin was such? As you saw, she had infection as well as, she has anemia. So can you guide us here?
Yes, she is 32 weeks and she has moderate anemia. So at this stage, I would directly start her on injectable iron. I would calculate the iron sucrose dose, and accordingly, I would start giving her. I'll start because already she's admitted, and then once she discharged, she'll come to the hospital maybe twice or thrice a week to take the iron injections, which will not only help to get the hemoglobin back to 10 and also start supplementing doses.
Absolutely. So would you be in favor of giving a blood transfusion to her?
Not yet. 7.4. I'll give injectable iron.
Yeah, I think hemodynamic instability and a very low PCV becomes the trigger, right? That's what you have been teaching us, madam.
So maybe I'll not give iron blood at this stage, PCV, but I'll give injectable iron.
Yeah, absolutely. Thank you so much. So quickly we move on to Shaili now. Shaili, we have been through the pandemic and we always found there was all of the while we had issues with ferritin. While when we are talking of parenteral iron, many times we have been told that it's always wiser to do a serum ferritin before you enter into parenteral iron, because there have been one or two medical legal cases which have made us do that and made the court question us. So would you want to comment on this, Shaili? Because if you see in this patient, her ferritin was 330. Dr. Shaili is there?
I think she is not going.
She's not there, ma'am.
Then Chaitanya, can you just take a recce of this ferritin thing?
So it is considered to be a surrogate marker for ID, and it declines early in the development of ID and is not affected by ingestion of iron. So based on the serum ferritin levels, iron deficiency clinic classified as mild moderate, which is wherein the levels are less than 70 to 100 micrograms, and severe when the levels are less than 20 to 30 micrograms. And iron deficiency is most likely absent if the serum ferritin levels are more than 100 micrograms per liter. This is more important because it helps us in identifying or differentiating between iron deficiency anemia and other types of anemias. So low SF has a good positive predictive value rather than a normal or high serum ferritin. And therefore, adding serum ferritin estimation to hemoglobin estimation seems to improve the sensitivity and pickup rate of anemia, as many women may have normal hemoglobin levels but have depleted iron stores in the immediate postpartum period.
Absolutely. Thank you so much.
May I add one thing? Basically, whenever there will be an inflammatory reaction in the body, the serum ferritin will also rise. So it may mask the original finding that it may be raised, but the patient is anemic. This we have to say that serum ferritin may be raised in the acute inflammatory conditions.
That's exactly.
So, Dr. Archana,
can I add, madam?
Yeah, Archana.
Maybe many antenatal women who have borderline hemoglobin between 10 and 11 gram%, when we do her serum ferritin levels, they are found to be very low in many patients. Even less than 10 are the counts that we have found. So if we add this to our antenatal workup in the first trimester or early second trimester, maybe we can prevent these patients from going from 10 gram% to a moderate or severe anemia as the pregnancy advances.
Absolutely.
So, but Girija, once a patient is having anemia clinically hemoglobin, it means that her stores are depleted. So generally, I mean, when a HB is less than 10, it already means that the ferritin is low. But in this case, though it's a case of iron deficiency anemia, the ferritin is raised maybe because of the inflammation.
Yeah.
Yeah, absolutely. So inflammation, and then I think the most important thing that would come in our mind would be, is it a COVID or any kind of a viral infection or even flu infection, maybe the reason why her ferritin is rising. So these things have to be kept in mind whenever we are trying to approach such patients. Now coming back to Dr. Sangeeta, now this was with our patient, Aster had this, but then let's say that her reports came this way: hemoglobin 4.8, hematocrit 15, MCV 90, RDW 26, retics were 0.2%. What would be your diagnosis?
Ma'am, as such, all the parameters, the RBCs are less, hemoglobin is very less, the leukopenia is there, that means only 1800 per mm cube is there, as well as platelets are also very less. So pancytopenia is there in this patient, including the decreased reticulocyte count.
Yes.
So just looking, I think it's so important that you don't jump on that. So will you immediately start her on blood transfusion, or what will you do?
If the condition is there, she is having hemodynamic instability, then only I'll be doing the blood transfusion. Otherwise, I'll wait for the investigation. We'll give the supportive treatment to her.
Yeah, before starting blood transfusion, this patient needs a hematologist opinion. Sometimes bone marrow is required. So after the bone marrow, etc., we'll start the blood.
Absolutely. So, Ketki, can you just enumerate the causes of pancytopenia, which we must remember, especially when such reports come during pregnancy?
In antenatal women, the most common thing is aplastic anemia. That is the commonest reason for pancytopenia, which may be related to pregnancy because of the hormonal imbalances between the placental lactogen and other hormones. And this may be idiopathic as well. And this may be because of other causes like leukemia, lymphoma, fibrosis, and megaloblastic anemia. Few cases have been found. And marrow replacement is another cause. And as madam has said, we need help of the hematologist for management of such cases.
Absolutely. So the important take-home message with these first two case vignettes was all anemias during pregnancy are not nutritional and only IDAs. They do not require or do not improve with blood transfusions. Cause of anemia can be confirmed in most patients by a logical approach, and it is often the physician who is refractory rather than the anemia, and this has to be remembered. So coming now to the second case quickly, and this is a case scenario which Chaitanya is going to take you all through, and I'm going to mute my.
Yeah. So welcome all, and I welcome Dr. Shaili also. She has just joined, so we can have her also giving her inputs during this second case. So she's Mrs. Mishra, 37 years old, married since 4 years, and this is a spontaneous conception for her, seeking second opinion for continuation of pregnancy because she has done her HbA1c and that has come to be 11.2, which is diagnosed at 10 weeks. She is not a known diabetic. She has got no history of PCOS or hypothyroidism, but she has got a family history that her both parents are diabetic. So what should be the approach, Dr. Richa? Should I ask her to continue with the pregnancy? Should I ask her to terminate the pregnancy? What should be our opinion, and how to counsel this patient?
So, since this patient has come with the raised HbA1c levels, and this suggests that, and that too at 10 weeks, this suggests that she has a long-term uncontrolled diabetes. So we need to prognosticate the patient properly, and there's a need to tell that the baby is at a very high risk of having congenital anomalies. So she would have to go for all anomaly scans and a strict control of diabetes. Actually, this is the case where preconceptional counseling and evaluation has more role, and since both the parents were diabetic.
Yeah, so basically I would look at it that she has been diagnosed with HbA1c of 11.2 at 10 weeks. So where was she till 10 weeks of gestational age? She had come for the first time, or whether the investigations were not done when she came for us to see for the first time and all. So Dr. Shaili, since you have joined, I would like to ask you, what are the effects of high HbA1c or high blood sugars in the mother that will affect the fetus? In what way? So that is going to guide me decision to terminate or not.
As her HbA1c is around 11, so there are around 25% chances of having congenital anomalies in this. So these patients should be counseled very.
Voice is echoing. Dr. Shaili, you must have joined by the two.
No, ma'am. I have joined only by my device. Why is
that?
Okay, because there is an echo coming.
Echo coming from everyone.
Now is it clear?
Yes. Yes.
Yes, sir. Okay. So if it is more than 11 in this case, so each and every system of the baby can be affected. And most common Most commonly, it is the cardiovascular system, which is most common anomalies in these patients.
Hello.
Sahithi, please look into the matter.
Shelly, you must be having speakers on.
I don't know what.
जरा आप शैली मैडम म्यूट करके एक बार देखिए तो
Everybody's voice is echoing.
अब नहीं हो रही, इसका मतलब शैली की तरफ से कुछ खराबी थी।
अब हो रही है?
नहीं, अब नहीं हो रही।
Okay. So in cardiovascular system, there can be ASDs, VSDs, or there can be the pulmonary stenosis, or there can, in neurological system, there can be anencephaly, there can be microcephaly, there can be neural tube defects. In GI tract, there can be the possibility of atresia, or there can be imperforate highness, or imperforate anus, or cleft palate. And the most pathognomic feature of this diabetes is the caudal regression syndrome or sacral agenesis. And in genitourinary system, there can be the malformation in the urinary system and the genital system of these babies.
Thank you, Dr. You have elaborated it very nicely, the different systems which are affected if the mother has got high blood sugar levels. And that is the reason why we should be very careful in counseling these patients, and then they have to take the decision accordingly. Obviously, we are there to counsel the patients. We are not there to take a decision on their behalf. So ultimately, the decision has to be taken by the couple. It's not us who is going to take the couple, which also as is a take-home message that we should be giving across. Next slide, please. Priya, madam. Yeah. So, Uma, madam, I would like to ask you, how will you evaluate her in the first trimester? And what are the cutoffs based on which we can say the risk which is associated with the anomalies to the baby?
You are talking only of H1A1C. Usually, we will first check for the diabetes by giving her the glucose challenge test, and then if the sugars are more than 140, then, but since the HbA1c has already been done in the first trimester, it's a case of pre-gestational diabetes. And if there's any HbA1c less than 6.5, there is a small risk of abnormalities. And her HbA1c is very high, more than it's 11. So there's almost a 25% chance of abnormalities. The most common abnormalities, as already mentioned, are of the CNS and the CVS. So once we know that she's diabetic, we'll thoroughly evaluate her. We'll not only do the routine pregnancy checkups like hemogram, urine, HIV, hepatitis B, TSH, and others. But for a diabetes, since the HbA1c is so high, 11, I will also do in the first trimester only a cardiac evaluation, a retinal evaluation, and a renal evaluation. And as told, we will already also check out the fetus by doing just viability scan at 7 to 9 weeks, NT scan at 11 to 13 weeks. That time also we'll check for the risk of PIH, because these two conditions are always associated. And we will also do an early anomaly scan, because many anomalies are diagnosed at 11 to 13 weeks. Then if the patient wants to continue the pregnancy, then of course we will do the double marker, and we'll do a complete anomaly scan by at 16 to 20 weeks. So we'll thoroughly work her up because she's planning to continue the pregnancy. Otherwise, if she had wanted to do an MTP, the question will not arise. We will do the MTP.
Would like to know your opinion on doing a glucose challenge test at the first visit.
Yes, yes.
Repeating it at 28 weeks.
We must do the test in the first visit itself. And if it's not possible, then of course we'll do at 24 weeks. But in the first visit, we could pick up cases like this, which are becoming more and more common. So the pre-gestational diabetes can be diagnosed if it's done in the first visit only. First time.
I just like to know the inputs from other panelists, that do you do glucose challenge test for every woman at the first visit? How many of you are following that?
Yes, we do glucose challenge test at first visit. Whenever a patient comes to us, we do it.
We are also doing glucose challenge test at the first visit itself.
Okay. So that's the
We do the
message which
gypsy
we have to
test,
give.
75 gram, 2 hours.
That's the message we want to give across, isn't it? Okay. Next slide, please. Okay, so this was about the first trimester, which Uma madam said. So how will you go about the second trimester fetal surveillance, Dr. Archana?
A second trimester will do a anomaly scan. In this case, we'll do little early, that is around 16 weeks. It can be done between 16 to 18 weeks. And during this anomaly scan, we'll try to figure out all the possible anomalies from all the systems, like the way we discussed. It can be a neural anomaly, CNS anomalies, gastric anomalies, renal anomalies, and cardiovascular anomalies. So we have to rule out a detailed anomaly scan. A 3D or 4D scan is advisable. And during this scan, we should also assess the cervical length and many other parameters, preferably a Doppler, fetal Doppler, to see the umbilical artery flow. And in these cases, we should again do a fetal echo at 24 weeks.
Yeah.
So that is advisable. Once the anomaly scan, everything is good, we can proceed ahead. And after that, a 4-weekly scan is advisable after 28 weeks to see for the amniotic fluid index, because these patients tend to have polyhydramnios. We can, and about the growth parameters also, because again, these babies are tendency to be macrosomic babies. So we have to rule out all these parameters and have a close watch on these patients with frequent ANC visits. And at the same time, we have to see and look for her PIH if she is developing the thing, and repeat her sugars so that whether the sugars are under control, and if she is on insulin, about titration of her insulin dose, or maybe if she's on oral anti-diabetic drugs, again monitor those things. So this is how the second trimester should be monitored.
Thank you, Dr. Archana. You have elaborated very nicely. So a few things which we need to keep in mind is that anatomy scan should be done a little early, say at about 16 weeks. Screening for genitourinary infections is very important. And then we keep repeating the scans every 4 weeks after 28 weeks to look for the abdominal circumference and the liquor. Yeah. Next slide, please. Girija madam. Okay, so how do you go for a microsomia screening? Dr. Kavita is not there. So Dr. Sangeeta, can you just take this question?
Yes, sir. We have to see the abdominal circumference of the baby as well as the effective fetal weight of the patient. We have to assess if the abdominal circumference is more than 90th percentile of the given gestational age, then we can consider that this patient baby is macrosomic. If, as given in this section also, if it is more than 35 centimeters, 36 or more than 36 centimeters, that means above the 93rd percentile. The baby's weight, effective fetal weight, will be around 4 kg or more than 4 kg. Then we have to assess, see that this baby is macrosomic baby.
Absolutely. There is no standardized algorithm for performing this antenatal screening. But one thing we need to understand is we have to take the axial plane correctly to view the abdominal circumference of the fetus. And then, as you rightly said, at the time of due date, if it is more than 35 centimeters, then it's likely that the baby is more than 4 kgs. And if we allow her to go in for a natural birthing, maybe we can land up in shoulder dystocia or something. So knowing the macrosomic status of the baby at term is important for us so that we can plan the delivery, mode of delivery of the patient accordingly. Okay, next slide, please. Okay, so Dr. Mangala is not there. I think Dr. Ketki, can you just take this question? How to look for the polyhydramnios? We said abdominal circumference and the liquor quantity, which we are going to look every 4 weeks. So just let us know, how do we look for polyhydramnios and at what weeks and how to go about it?
We need to do serial ultrasound of this patient starting from 28 weeks every 4 weekly, and we can look for the amniotic fluid index in all 4 quadrants. And if it is more than 24 centimeters, or a single maximum vertical pocket is more than 8 centimeters, which is indicative of polyhydramnios, and it is also suggestive that the BSL control, there is not tight BSL control of this patient.
Right.
And
so it must be assessed at around 28 weeks, and then it should be repeated every 4 weeks, isn't it?
4 weeks.
And fetal hyperglycemia, which causes osmotic diuresis, is the reason why the women land in polyhydramnios. Next slide, please.
Polyhydramnios is a sign of uncontrolled sugars, which we have to know as a message.
Right.
That is polyhydramnios, that means sugars have been uncontrolled. You are not catching them on your lab tests.
Okay. So, tell me, Dr. Sangeeta, what is the correlation between hypertrophic cardiomyopathy and gestational diabetes mellitus? Is there a correlation? And if yes, how do we look for it? How frequently we look for it?
Yeah. This is a new entity. In fact, I have read just when you gave us this case. This hypertrophic cardiomyopathy, the diabetic mother's baby has got the tendency to have this hypertrophic cardiomyopathy. Even the patient is having a good sugar control, then also the baby can have this HCM. In this, the insulin receptors are more on the baby's heart, or more on the affinity, and the expression of the insulin receptor is more on the intraventricular septum. As the insulin, this hyperinsulinemia occurs, this is the anabolic steroid. This causes the hypertrophy and hyperplasia of the interventricular septum. So this causes the increased interventricular septum, or the width, as well as the wall of the ventricles also get hypertrophied and hyperplastic. This may cause the ventricular hyperplasia also. But the thing is that the main part, which is the relieving factor in these cases, is that this is the reversible factor. When the baby takes the birth, this usually goes off. This doesn't remain for the life.
Okay. Thank you, Dr. Sangeeta. Okay. How do you look for it? What are the cutoffs for the interventricular septum or the the wall thickness? Yeah.
The interventricular septum thickness is more than 4.5 or more than 4.5. And if we take the ratio of the interventricular septum as well as the ventricular
myocardial wall thickness.
left myocardial wall thickness, if it is less than equal to 1.18 centimeter, we can consider this to for the baby to have hypertrophic cardiomyopathy, and we have to later on see by the serial echo of the baby, we have to follow the baby for these conditions.
Okay. So, Dr. Ketki, how would you go regarding the evaluation of this mother? When to start? What all investigations you would like to do? How frequently you would like to do it? We know that she is now a known case of diabetes, a diagnosed case of diabetes. Yeah.
Yes, being diabetic, she is at risk of worsening of her diabetes and developing other complications, including the cardiac, renal, and the ophthalmic complications. So for this, we would like to, apart from her routine investigations, I would like to do her kidney workup. In that, blood urea, creatinine level, the spot urine to creatinine ratio, the capillary blood sugar monitoring needs to be done and needs to be kept under control. The fasting should be kept less than 92 mg/% and postprandial ideally less than 120 mg/%. That would be the target limits. Apart from this, I would like to screen her for asymptomatic bacteriuria, because UTI are more common in diabetic patients. So that screening should be done in the first trimester, can again be repeated in the second trimester.
Yeah.
In second trimester, we have to keep a watch. She might develop preeclampsia. So frequent monitoring is required. Then these patients are, if they are over diabetes, they can develop retinopathy. Proliferative retinopathy is a risk during pregnancy. So fundoscopy needs to be done, and evaluation of heart by doing ECG and 2D echo in the mother. That is advocated in second trimester, so that we can follow them up accordingly in the third trimester. With the help of the physician.
So many times we are so much engrossed, in the baby, that we forget that the diabetes could also have an effect on the mother.
Yes.
And that's why monitoring mother is equally important, but maybe sometimes we may overlook that. That's the reason why we have to be very careful, and that's the message what we would like to give here. Next slide, please. Okay, so at 30 weeks of scan, she is now showing hydramnios. What will you think? She was not showing hydramnios as of now, but then at 30 weeks, the sonography was done and it started showing hydramnios?
The hydramnios means poor sugar control. So we'll have to do a tight sugar control. If she was only on diet, of course, we'll start insulin. If she was on metformin, we'll add insulin. If she was already on insulin, we'll increase the dose of insulin. We'll ask the mother to keep a strict self-monitoring of blood sugar 5 times a day. And we, as Ketki said, we will keep the fasting, try to keep the fasting below 95 and PP sugars below 120. We should check out again her diet, that she's doing her diet, exercise, and we will add the insulin and try to control the sugar, because hydramnios means we're not doing it well. And
so as rightly said by Girija madam, that even though the sugar monitoring is showing that she has got normal sugar levels or within the expected range, but if she starts showing hydramnios, even though the reports are normal, we should assume that she has not a very good sugar control and start treating her accordingly or adjusting the doses accordingly. Yeah.
And for polyhydramnios, as you have said, we will ask her to take rest so that she'll not go in preterm or PROM. And I have not used indomethacin for polyhydramnios. And since the polyhydramnios not too much with rest and tight control of sugar, I think we should be able to pull on the pregnancy.
So anyone who has experience with indomethacin here?
I will talk about indomethacin if nobody minds. So indomethacin is something which I very rampantly use in all my pregnant moms because of fear. Even if I use it as a tocolytic, a sustained, maintenance tocolysis. Sometimes if they have pain with leukocytosis. So in such patients also I use them, and in women who have polyhydramnios. And I have had, certain experiences where we had given it because we had done a cervical encerclage and the patient is, on strict bed rest. And then there's always a fear of preterm, and I've used indomethacin. Sometimes the liquor reduces, but you stop using it, it regains back again. So basically the deterrent for indomethacin is the oligohydramnios which occurs because of it. But it can act as a wonderful anti-inflammatory or temporary tocolytic also for a while and keeps the pain away. However, you have to be careful. It can cause renal abnormality, renal dysfunction, and it can be sometimes not tolerated well by women, and definitely should not be given beyond 34 weeks of gestation.
So, madam,
so at what time when you start this? At which gestation you start?
After 18 weeks of gestation till 34 weeks of gestation, I give them.
And which dose,
not continuously. It's only an allocate of 15 days.
Okay. And dose,
what is the doses? What is the doses, madam?
75 milligram SR formulation is there. 75 milligram BID for 15 days.
Thank you, ma'am. Thank you. Next slide, please. Okay, how good should be the sugar control? Should we have a very tight sugar control or thoda sa idhar udhar chalta hai?
The maternal sugar should be well controlled, keeping fasting less than 95, a pre-meal less than 100, and a 2-hour sugar level of less than 120. And to ensure this, we have to involve the mother, and she should have good education about, especially about the self-monitoring of the blood sugar levels and the fetal movement counts. These two things are very important, and restricted diet that we all know, adaptive diet. We should encourage her to have regular exercises, apart from giving IV insulin and subcutaneous insulin. And if these we will add surely, no doubt. But then home monitoring and self-monitoring of blood sugar is very important, with an aim to keep the blood sugar levels controlled. Should be done 3 to 5 times a day.
Correct.
And fetal movement counts are
importance of monitoring the sugars frequently is what needs to be counseled to the patient. So as you rightly said, patient's maternal education is very important. Education regarding the diet, regarding the exercise, and then the sugar monitoring and taking the medications at the right time in the right doses. All things are very important. And when we go to home monitoring, probably that's how we are going to add up to the overall care of the patient. Because if you ask her to come down 5 times a day or 6 times a day to the hospital, it's not possible for her.
She will not be able to come.
Another thing what is important is the fetal kick count. So how will you counsel the patient regarding this fetal kick count, Dr. Richa?
We'll start counseling her from 28 weeks onwards. We will ask her to start doing the counts. Less than 10 counts over 12 hours, this usually indicates a fetal compromise and needs evaluation. Because it is definitely a measure of the CNS integrity and the function. And in order to counsel her, we can ask her to either she should have some, like earlier times we used to ask her to have paper and just clear it, and then you should count it and tell us, like anything.
It's a very simple method which is easily which can be easily taught to the patient, and she can do it very easily at home on her own, and she can just get in touch with us if, as you rightly said, the fetal movement count is less than 10 in 12 hours or so. That's absolutely right. Next slide, please. So now she has got a likelihood of going into preterm labor, and we would like to cover up with steroids for her. Now, what difference does it have as compared to when we are going to give the steroids in a non-diabetic woman? Would you like to admit her? Would you like to give the doses on the OPD basis? Yes.
I will like to admit this patient because with steroids, there can be the sugar control can be hampered with that. So these patients should be admitted in the facility.
So do all of you agree that she should be admitted?
Yes, yes.
Yes.
And
so
then
all women, if you have to administer steroids, should get admitted.
Yeah.
Basically, here we have the risk of preterm also. So both the things can be monitored, the sugars and the preterm activity, uterine activity.
And when we give the steroids, we have to increase the dose of insulin also. If she is on insulin, then we have to increase the dose also, so that the increase in the sugar can be counteracted with that insulin.
But admission,
yes,
admission is not always necessary, I think.
Okay, so there is a difference of opinion. Dr. Richa says that there is no need for admission every time. Dr. Girija, madam, would you like to comment on this?
I will want to be safe in this particular patient because she has shown polyhydramnios, and then when the sugars really shoot up, and example, if it's a GDM patient, usually we don't get into these problems, but if it's a pre-diabetic, then she may show even diabetic ketosis and ketoacidosis. So I would be definitely concerned, and I will also do an NST, electronic fetal monitoring, for the baby as well. Because so it will depend on the condition of the patient and the severity of her diabetes and the the consequences of the diabetes.
If it is controlled diabetes, then we don't need to admit.
We may consider, yeah. And if it's a GDM, then maybe GDM who is well controlled, and you're giving us steroid just
but if it is still known diabetic, then it's better to admit her. Yes.
Once we give them steroid,
whenever we give steroid to a diabetic patient, the sugars shoot up. It's always better to admit, monitor the sugars and give the doses.
And even the fetal heart slows down, with the steroid. And then we are really concerned. Hypoglycemia se ho raha hai, steroid se ho raha hai.
How will you monitor the fetus in this case? So would you change the way you monitor the fetus in a diabetic woman as compared to a non-diabetic woman?
So the frequency the frequency basically increases. As such, we monitor in other patients. Here, the frequency with the NST will be increasing, as well as we have got more dependency on the ultrasound findings.
Okay.
And
so how frequently would you like to go for the ultrasound? Every 2 weeks, every 4 weeks?
Every 4 weeks.
In the last trimester when she is near about delivery, even every 2 weeks we have to go for. In my practice, the NST, because it is available with us, so we go for twice weekly with the NST. We can find out the high risk cases here.
Yeah.
Okay. Anyone wants to add to what Dr. Sangeeta has said? So what all things you will monitor when you are monitoring the fetal growth? So the abdominal circumference in the second and early third trimester is what we should be going for, and then repeat it every 2 to 4 weeks, as Dr. Sangeeta said. Initially, we may go for every 4 weeks, but as we come close to the delivery, we may repeat it every 2 weeks, and can be helpful in giving us the management guide. Evidence reviewed from RCTs indicate that modification of metabolic management based on the fetal growth restrictions measurements may improve perinatal outcome, or at least be equivalent to a standard intensified management. Less intensified management may be allowed with normal growth when the baby is not showing any signs of fetal changes in the growth, although the consensus was that some SMBG should be continued. So what investigations will help in preventing the stillbirths in a diabetic? Uma, madam?
The problem with stillbirth in diabetic is it is sudden. Like we cannot predict the stillbirth many times. Sometimes we may, and it's because of the raised HbA1c, because all the hemoglobin is bound to glucose, and there is hypoxia to the fetus, which is one of the most important causes. And other is the vasculopathy, which always accompanies diabetes. So there could be placental vasculopathy associated preeclampsia. Then many times the sugars may be very low, very high. There could be ketosis. And as already said, there is this hypertrophic cardiomyopathy, which can also cause a sudden stillbirth.
Okay. So the important thing to note here is that it, as you rightly said, the stillbirth is sudden, and there is nothing which can prevent the stillbirth if it has to occur. So coming to my last slide of this case, that when to deliver and how to deliver, Dr. Archana. Are there any guidelines that we should abide by?
With the proper counseling, good monitoring of the mother and the fetus, with a good nutritional therapy, and the patient is on insulin or anti-hyperglycemic drugs like metformin, we continue with the monitoring of the baby, and that is the fetus and the mother. As discussed, the sonography should be done around every 4 weekly, but towards term we should do at least twice weekly with good NST monitoring that we have discussed. So when now we are towards the term, ultrasonography at 37 weeks, if it suggests the expected fetal weight is around or more than 4.5 kg, then again we should do a counseling, and a planned delivery at 39 weeks should be done. But if the estimated fetal weight at this age is less than 4.5 kg, again counsel and a trial of labor can be given with a strict vigilance, and expected management can be done till 41 weeks, but finally at the induction of labor should be done by this time. Now, if it is uncomplicated pregnancy, but with poor glucose control and on nutritional therapy and using all the anti-hyperglycemic agents, then antenatal fetal monitoring should be started at 32 weeks, and same with that amniotic fluid index on the scans, ruling out polyhydramnios, and doing bi-weekly NSTs. So again, an ultrasound to estimate the fetal weight at 37 to 38 weeks. And if it is again more than 4.5 kg, go ahead with a planned cesarean section. And because there is chances of shoulder dystocia and because of macrosomia, so a planned delivery is much more advisable. And if the fetal weight is again here less than 4.5, we can give a trial of labor and accordingly monitor the labor and deliver the baby.
What would be the cutoff for Indian women, Dr. Uma madam? And I can see that Madam Kiran Sinha madam has said that if the patient is on insulin, this case should be delivered at 37 to 38 weeks of gestation. Any comments?
I think in Indian scenario, we should be taking as a 4 kg.
4 kg, yes.
Because before, yes.
Yeah, because we
Ma'am,
can't take
even
Uma,
in
madam?
infant
4
female,
kg in Indian women.
3.5 kg, we have to be vigilant. We अच्छे
Uma,
नानी याद आ
madam, you are
जाती है when
muted.
we deliver the patient.
Yeah,
3.5 or more.
in our
Yeah.
Indian scenarios, we
Yeah.
should take 3.5 to 4 kg as a limit. And main risk is macrosomia and shoulder dystocia.
No, I would take
Archana.
3.5 as a cutoff.
Yeah, Archana, Dr. Archana, 3.5 and 4 kgs, it's a 500 gram difference. So would you like to go with 3.5 or 4?
I'll like to go by 4 kg actually. 3.5 we deliver otherwise also. So 4
Yes.
kg should be the
I think if it is showing 4 or more than 4, we should go for the elective LSCA. So after discussing it with the patients.
Girija madam, what is your take?
I think we should also
What
clinically
did you-
assess, because many times sonography gives a wrong estimate of weight towards the end.
Yes.
The sonologist may say that the baby is 3.8, but actually the baby may weigh only 3.2 kgs. And
yeah,
then,
it happens many times.
yeah, so you have to be factoring for many things, because finally they are going to look at the weight depending on the biometry, where there can be some sort of a water retention in the baby because of the steroidic effect. And therefore, we have to do a very individualistic assessment and then consider delivering them vaginally or abdominally. And finally, we must definitely find the safest route, because shoulder dystocia is something which most of us are not very well with. There are, like, we have encountered them many times. I have been, and I would like to share that they are not very happy situations.
The Apgar scores come down. Yeah.
And these patients also, we have to remember that diabetic mothers have a very high incidence of going into atonic PPH, because their myometrium, somehow because of the high insulin resistance, the myometrium is not very well responsive to oxytocin. So we have to be very careful about PPHs also in this patient. So we may end up delivering a wonderful 4 kg baby happily, and she would land in atonic PPH. So this is something that we have to remember. That doesn't mean that I'm saying universally do a C-section, but individualized patient. And as Uma madam said, I would like to be 3.5 kg, a little humble and, and not try to be very adventurous with a 4 kg baby.
Thank
Because,
you so
you
much.
know, in diabetes, it is the shoulders which are bigger than the head.
Yeah.
So though the weight may be not much, still there's a chance of shoulder dystocia.
Correct.
Yeah.
Yes.
Thank you so much. With this, we will
I
move
think, Chaitanya, we should now end the panel, because we have
I
already
think so.
superseded
Yeah,
our
it's already
time.
8 o'clock.
Yeah, it's already superseded our time. So I would like to take this to a conclusion. Yeah. Okay, so we had decided to take anemia and diabetes because they are commonest things. And I always feel that every antenatal mother, and all of us in the panel would agree, that we have to look at them very, very carefully. And we have to ensure that they are surveyed properly throughout the antenatal period. And I always like to speak about this dystosis score. It is not only because we have been the part of its initiation, but I feel that these are simple risk assessment, pointers which we can use for every antenatal mother. The moment she comes to you, and then evolve it over a period of time, such as if she's putting on too much weight, or you find diabetes later, or if you find her to be hypothyroid. So this dystosis score is not only for identifying hypertensive disorders, but any kind of an adverse pregnancy outcome. Also, you can be on guard when these patients have this kind of a risk factor. And I'm very happy to say that many of our Foxians have put these charts in their OPDs and have put them on their antenatal cards. And now there are 3 to 4 publications to validate this score. And I think all of us must therefore adopt this score, which will help us in identifying women at risk. And you can put them through this wonderful algorithm, which talks about screening, surveillance, dietary supplements, education of the woman at every walk of time. And this has to be not only nutrition, but physical activity level. And recently, this is something that I would like to share with you, which was a publication in the NAGM 2022, that moderate exercise of more than 40 or equal to 140 minutes per week will cause 40% reduction in eclampsia. Likewise, aspirin starting very early, even 100 milligram would work. And then dietary calcium intake is very low in our country, especially it's less than 900. If you give them calcium supplementations, and if you do time birth, of course, this was in context of preeclampsia, but I think it works for all antenatal conditions. And I've also shown you an excerpt of a weight chart, which I follow in my antenatal OPD. In the beginning itself, if you can see that the woman is putting on a lot of weight, you can start talking to her that please don't get into this because you may land up in unnecessary complications as we go by. And these simple measures can help. So educate the patient and her family. And there are wonderful things here. There is a WHO recommendation on antenatal care for positive pregnancy experience. There's a dietary guideline for Indians, which is a wonderful manual which we can use in our antenatal practices and encourage our patients. And of course, we have the FOXY Universe PCA partnership protocols in OBGYN. And I had the privilege of becoming one of the editors of this. And there are a lot of things which have been enlisted, which you can use as your checklisting in your practice. At the end, I would like to request all of you with folded hands to kindly support Chaitanya Ganpule. He is not only a POG POGS member, but he is a very, very good academician, an excellent human being. And he is somebody who has a lot of, affinity towards FOXY, and he really wants to do a lot for the community and the members. And I think he is befitting a role to become the chairperson of, the endocrinology.
Yeah.
And this is something that only your support can help him win. Thank you so much. And
Thank you so much, Girija madam. And I would like to thank Girija madam because she's the one who has put in lots of efforts to do this panel discussion, put the slides together. And I was there to I was there with her, but it's all her efforts that has brought to all this discussion today. Thank you
but
so
I
much.
want to clap for all the panelists for wonderful.
Chaitanya and Girija, good job, wonderful. And yes, I'm sure all our Kanpur friends will support you, Chaitanya. You deserve
Thank you,
that.
sir.
And in reciprocation, we are also going to support,
Yes.
Kanchanji and their
Yes, yes.
Thank you. Sir, our good wishes to Chaitanya and to, I need your blessings also.
Certainly.
For Girija ma'am and Sanjay sir and all the Pune society and our society.
Yes, ma'am.
Wish you all the best.
Thank you.
Thank you, madam.
Thank you.
Thank you once again for giving the opportunity. Thank you, sir.
I think Dr. Sunita madam will take the talk, or
no, the phone call that she made to me, I thought she had informed you that she has some emergency which had cropped up. So she had requested me to take the panel before. So if you can connect to her and find out, Kanchan.
Yeah. I think the chairpersons of her session.
So I hope the panelists like the set of questions and the cases.
Very much. Very much.
Definitely, ma'am.
I think when Uma says very much, then I know I have achieved it.
Okay.
It was an excellent panel discussion, madam.
Please, Uma, madam.
Yes, teacher, our teacher of teachers.
Thank you so much, Girija and Chaitanya, sir.
Thank
And
you.
all the best to you,
Madam,
Chaitanya.
you are our teacher.
All the best to you.
Thank you, ma'am. Thank you.
Thank you, madam.
एक्चुअली क्या है ना, सभी फॉक्सियंस को राइट होना चाहिए चेयरपर्सन को वोट देने का. खाली प्रेसिडेंट सेक्रेटरी है तो वी आर हेल्पलेस नाउ बिकॉज माय टेन्योर हैज बीन फिनिश्ड. We can
Madam,
only ask
you
our,
can
Your wishes are
influence.
more than.
You can influence though.
but now it should be implemented in the Foxy society ki from next year time all the Foxys must vote for the chairpersons also. Why not?
Yeah, true.
Because I think the chairperson committees are more important than as a whole Foxy committee, because the chairperson, they are doing very much good job in their respective societies. Whether it is HIV, whether it is Safe Motherhood Committee, whether it is LCD, because as a whole, their work represents the whole society, whole Foxy society. It is my wish, though I am not supposed to make any thing in the society, but this is my wish.
Great leaders of Foxy, they are hearing, they may implement it later on.
Like Dr. Sanjay Gupta and everything,
Yes,
जो भी past president है, I will request them to implement this thing in the future also.
Yeah. Dr. Seema Dwivedi, you are there. I think I called Dr. Sunita madam, and she said that I'm busy, so I will not be joining. So you can
No
give the
problem,
vote of thanks.
Sangeeta. Kanchan, next time we can keep a talk anywhere.
Yeah.
Yeah.
Dr. Seema, unmute yourself.
Thank you, ma'am. Am I audible, ma'am? Hello, am I audible?
Yes.
Okay, ma'am. Traveling in train, it is with great pleasure and gratitude.
So, Dr. Seema, I can take. Hello.
ये तो कहीं भोले बाबा की नगरी से आ रही होंगी इसलिए ट्रेन में सीमा
Seema, you are muted. You are muted. Muted. Seema.
है ना वहाँ पर हेलो स्टेशन पे तो वहाँ बंदरों ने मेरा आम भी छीन लिया. I was carrying my mango.
सीमा आप म्यूटेड हो गए.
लेकिन आवाज तो आ रही है.
ओके मैम. आ रही है मैम मैम आवाज. अनम्यूटेड नहीं है मैम, अनम्यूटेड है.
हाँ नहीं आवाज आ रही है, बोलो.
आ रही है ना मैम. हाँ. So I convey my thanks for this remarkable webinar jointly conducted by KOGS and POGS, and to the entire organizing team I extend my heartfelt appreciation to each and every one of you who has participated in this event. Our deepest gratitude to our esteemed chief guests and guest of honor for their gracious presence, heartfelt obligations to speakers and panelists for their expertise, insights, and captivating presentations have truly enlightened and added immense value to this webinar. My gratitude to the chairpersons and experts for the echoing comments and enthusiasm have made this webinar truly interactive and enriching experience. Your presence and contributions have reinforced the significance of our collective pursuit of knowledge and growth. We extend our thanks to the technical support team who has worked tirelessly behind the scenes to ensure seamless execution of support. Your commitment to promote knowledge, shaping professional development is deeply appreciated. I would like to express gratitude to all the participants who took the time out from their busy schedules and joined us. Lastly, I would like to acknowledge the organizing team for their relentless efforts in planning and executing this webinar. Your dedication, creativity, and meticulous attention to detail and every aspect of this event was executed flawlessly. In conclusion, I extend my deep
असल में वो चला जा रहा होगा बीच में
नेटवर्क.
हाँ नेटवर्क चला जा रहा है. चलो कोई बात नहीं, हो गया.
Very good. Bye.
She has done her job.
Wonderful job.
Dr. Seema, okay. My sincere regards and thanks to chief guest, all the guest of honors, speakers. Special thanks to Girja madam, Chaitanya, Dr. Sanjay Gupte, my whole team, presidents of both the societies, Dr. Usha Goenka, Dr. Meenu Agrawal, who has taken pains to speak from the Dubai even, and Dr. Vaishali could not join. Dr. Girja madam, you were added a bit late in the group, but you moderated as our panel with the full expertise. All the panelists, Dr. Sangeeta, Richa, and Shelly, and all the 4 panelists from Pune Society, they were very expert of the topic and discussed very well. Dr. Chaitanya, all the best wishes. Dr. Kiran Sinha madam, thank you so much for your expert comments and best wishes. We all are obliged here also in the Kanpur society as well as. And thank you so much. And thanks the Shield Connect people who have taken pains since long with me. And really, I appreciate Sahiti and Chitrakala who did their job with a great patience day and night with me, and they immediately prepared the flyer and gave full time. Thank you very much. Thank you, everyone.
Thank you. Thank you, madam.
Thank you, Girja madam. आप muted हैं madam.
Thank you.
Thank you, ma'am. Bye bye.
Bye.
Bye. Thank you, ma'am.
Nice. Sangeeta, nice to touch base.
Thank you. Bye.
Okay.